Welcome to our annual conference. Today's conference is co-sponsored by the two centers funded by the Massachusetts Department of Mental Health. We are the Massachusetts General Hospital Center of Excellence in Psychosocial and Systemic Research and the Implementation Science and Practice Advances Research Center, or iSpark, at UMass Chan Medical School. I'm Corey Cather, a clinical psychologist and researcher, and I have the great pleasure of directing the MGH Center of Excellence. I'm joined today by my colleague, Dr. Megan Kelly, also a clinical psychologist, researcher, and director of iSpark at UMass Chan Medical School. Our topic today is innovative prevention and treatment strategies for co-occurring mental health and substance use challenges. We know that substance use and mental health disorders often go hand in hand, and that despite advances in the development of safe, effective, and flexible treatment strategies, many people are unable to access best practice treatment models in real-world settings. Progress requires new ways of thinking about screening, prevention, and scalable treatment models that harness the input and benefits of peer support. Today, we will hear about cutting-edge work that is on this topic, and this will be presented by Dr. Eden Evans, Dr. Melissa Anderson, Dr. Alex Wilkins, Dr. Randy Schuster, Dr. Laurel Kelly, and the privilege of hearing from a fantastic panel today with Val Comerford and Celeste Clerk, both of whom are certified peer specialists and directors of Massachusetts DMH Recovery Services. On the panel will also be Scott Francis, a highly inspirational certified peer specialist and recovery coach who is at the Massachusetts Organization for Addiction Recovery. In addition, we are very privileged to have Commissioner Brooke Doyle starting off our program. Before we come to the Commissioner's remarks, Dr. Kelly and I would thank to take a number of people who have been so important to the work and remission of our respective centers. At MGH, we could not do this work without the support of our Department of Psychiatry, in particular, our excellent chief, Dr. Maurizio Fava, and Lori Ball, the executive director for the department, who, as many of you know, will be retiring later this year. Lori has been integral to our center's collaboration with DMH, and all I can say is that I will miss her and cannot thank her enough. Our center is fortified by cross-pollination with so many other groups at MGH, and I'd like to take this opportunity to thank them as well. The MGH Psychosis Program, co-directed by Dr. Daphne Holt and Dr. Oliver Freudenreich. The MGH Center for Addiction Medicine, founded and directed by Dr. Eden Evans, who will be presenting today. And the MGH Division of Public and Community Psychiatry, directed by Dr. Alex Karoglian. I'd also like to thank our wonderful team of peer consultants, guided by the wisdom and steadiness of Dr. Ann Whitman, and all of the staff in the center, whose commitment to work, professionalism, and support of one another consistently exceeds my expectations.
For iSpark, I want to thank our Department of Psychiatry for their unwavering support, including our chair, Dr. Kimberly Youngers, who has done an incredible job partnering with us to advance behavioral health research. Many thanks to our Deputy Director, Dr. Melissa Anderson, for her leadership and assistance with iSpark's direction, community engagement efforts, and workforce development. I would also like to thank Dr. Marcia Ellison for her excellent work with our technical assistance and communications programs. I'm also grateful to our Vice Chair for Research, Dr. Tony Rothschild, and our Vice Chair for Psychology, Dr. Phoebe Moore, for their dedication to research and the well-being of our faculty. Many thanks to our Department of Population and Quantitative Health Sciences, who have been great collaborators in implementation science research. I would also like to thank Paula Silverman and Holly St. Jean for their assistance in taking care of our staff. And many thanks to all the wonderful faculty and staff of iSpark who are transforming behavioral health care. We also want to express our gratitude for the support we've received from the Department of Mental Health, and in particular, thank Dr. Margaret Geyer, Director of Workforce Development and Research, and Dr. Kathy Sanders, Deputy Commissioner for Clinical and Professional Services, whose invaluable guidance helps ensure that our work aligns with the strategic priorities of the Department of Mental Health, benefits the residents of the Commonwealth, and strives to improve health equity.
A few comments on the logistical aspects of today's presentation. First, here are disclosures. None of these will be related to anything that's covered today. We are offering 3 CEUs and 3 CMEs for the disciplines listed on this slide. In terms of requirements, it's important that people attend the entire program. Attendance is based on sign-in and sign-out times on Zoom. We also will need an evaluation in order to issue CMEs or CEUs. And since attendance requires that your name appear correctly on Zoom, we just wanted to do a quick review of how to change your name on the webinar in case you need to do this. Please stay with us as we go through a few technical assistance points over the next few slides. But please know too that you can put any difficulties or questions that you're having in the Q&A box, or you can call the MGH Psychiatry Academy customer support number that you received in your confirmation email for help with anything technical. So to change your name, you want to click on the participants button, which is in the lower center of your screen. It will open a side box labeled participants on the right. Find yourself on the sidebar and then click the more button to the right of your name. You then can select rename and type your name in and click submit. This live stream is being recorded and will be posted on our websites and YouTube channel. We encourage everyone to please submit an evaluation at the end of the program, and we will be saving some time before 4:30 p.m. to do so. We truly value your input and read through every piece of feedback we receive carefully. So what you say there matters, and we would be very grateful if you could take the few minutes at the end of the program to complete these evaluations. The links to the evaluations will be shared in the chat and on a slide with a QR code before we end today's programs. It will also be emailed to all attendees after today's program. Please use the Q&A button shown here to send us questions and comments rather than the chat. And also for those who would like to enable the auto-generated captions, you can do this here by selecting the Show Captions button. We are very grateful today for the contributions of an outstanding ASL interpretation team. And we also wanted to provide some guidance on how to get the best webinar view for all of our participants. We suggest clicking the View button in the top right, choosing the side-by-side speaker option. Then to change the size of the slides or the presenters on your screen, you can click and move this gray line here to either the right or the left. And now it is my great pleasure to introduce Commissioner Brooke Doyle, who will open our program today. But before doing so, would like to take some time to highlight the notable achievements spearheaded in behavioral health reform by Commissioner Doyle and her team. Over the past year, not only has there been greater attention to culturally and linguistically relevant treatment, there have also been measurable gains in key areas such as access to treatment, decreased use of psychiatric emergency rooms through innovations such as the 24/7 behavioral health access line, and the community behavioral healthcare system. There have also been key initiatives that look towards creating a future workforce that reflects the diverse communities of Massachusetts and is trained in culturally responsive, trauma-informed, person-centered, and evidence-based practices. Commissioner Doyle, thank you very much for being here today.
Thank you, Corey. And welcome to everybody. I'm thrilled to be able to open your session here today. I'd like to start by thanking Corey Cather at MGH and Megan Kelly at UMass Chan for their leadership and great partnership with us and with each other. And I'm grateful for the ways that they have responded, often spontaneously and quickly, for our urgent requests for assistance when they come up. This conference is co-organized by both Centers of Excellence, and they alternate years to formally serve as host. So thank you to the MGH team for your hosting today. To start, I'd like to just take a very brief moment to welcome and congratulate Megan Kelly, who is the new director of iSpark, our DMH Research Center of Excellence at UMass Chan. We were fortunate to have had Marianne Davis's leadership and her work for many decades, and I hope she is happily enjoying her retirement. I appreciate all who assisted in assuring a smooth transition for Megan. She joins iSpark from the Bedford VA and brings her portfolio of research and colleagues and helps expand and enhance research that addresses the needs of people that DMH services. Also, just a quick plug. How many of you have taken advantage of the technical assistance that's now available? At its most basic, if there's an academic article that you want to read, just ask and they'll be able to send you a copy and the full text article. If there's an area of interest, just ask for a literature review. Among the many things that we ask of our Centers of Excellence, there are two that are really critically important to me. One is that we facilitate the rapid translation and dissemination of research findings for providers, persons served, and the community at large. And then second, that we shift the culture and operation of research by actively engaging potential research users and beneficiaries, including DMH staff, its operated and contracted programs, mental health service providers, family members, service delivery partners, and stakeholders from across the state in order to produce research that is both relevant and rigorous. Today's presentations illustrate the ongoing commitment and success of both Centers of Excellence in addressing these priorities. You'll hear about research developed in partnership with people with lived experience that immediately informs current services. You'll hear about efforts to expand and dismantle barriers to substance use treatment across the diverse Massachusetts communities. Today's presentation are just a quick peek at a few of the projects that are happening at both of our centers of excellence. I hope that today you, like me, will feel energized and inspired by today's presentations and will leave wanting to know more. In the old days when we met in person, you would always get some swag. Who misses the swag? And you would get a binder full of flyers and inserts. In the absence of a physical binder, I want to invite you to go to DMH website or to either of the Center of Excellence websites, and you can see the center's annual reports for a fuller picture of what they do. If you're inspired with an idea or an interest that you'd like us to pursue, you can always reach out to the Centers of Excellence directly or to Margaret and Kathy if you have ideas or questions. And now, enjoy the rest of your conference. Thank you for allowing me to join you today to help open this important opportunity to hear about all the advances through our Centers of Excellence.
Thank you so much. It is now my great pleasure to introduce my close colleague of almost 25 years, Dr. Eden Evans, who is a professor of psychiatry at Harvard Medical School and the founding director of the MGH Center for Addiction Medicine, as well as the director of the MGH Addiction Research Program and Research Fellowship in Addiction Psychiatry. Dr. Evans is an outstanding psychiatrist, mentor, researcher, and colleague. She conducts research at multiple levels of analysis, some work focusing on understanding brain mechanisms underlying addiction, as well as treatment response, and some focusing on establishing best practices for the treatment of substance use disorder. Dr. Evans is an internationally recognized researcher who has made major contributions to establishing the evidence base for tobacco use disorder treatment among people with mental illness, and for advancing our understanding of how to deliver safe and effective treatments in real-world settings. Some of her work involves overcoming biases and misconceptions that people with lived experience, providers, and family members have about what constitutes effective treatment, and some involves appreciating and intervening with the social context of many individuals with mental health challenges who smoke or vape tobacco. Dr. Evans is extremely committed to mentoring the next generation of care providers and a fierce advocate for patients being offered optimal care. Her research and mentorship has contributed to improving the care for individuals with substance use disorders, those with mental illness, and those with both. And we are so privileged to have her speak today. The topic of her talk today will be a case against purity, what we can learn at the intersection of mental health and substance use challenges.
So thank you, everybody. Sorry for the technical difficulties there. This is fantastic. I'm here to present a talk that I've now given at the National Institutes of Health at an international meeting, really speaking to researchers, to funders, and actually reviewers of grants and papers to try to urge work to be carried out really at the intersection of mental health and substance use disorder rather than one or the other, in order to help us sort of guide treatment for folks, the many folks who have both. Next slide. This is just telling folks what we know already People with mental health disorders tend to have a substance use disorders with a high prevalence. And other than tobacco use disorder, they're not that different across mental illnesses. So for schizophrenia, you see 50 to 90% develop tobacco use disorder. For major depressive disorder, it's about 36. But then for alcohol use disorder, sort of 25 to 30% is common. For cannabis use disorder, 15 to 20 for depression, 25 to 50 for schizophrenia. For cocaine use disorder, it's really not that different. Amphetamine and opiate use disorder, it's really not that different. And it makes you wonder, since it's so common, it's maybe more common than some of the symptoms that are part of the syndrome. It seems that perhaps a substance use disorder, it makes sense for that to even be part of the syndrome, if you will. It's a little bit facetious, but not really. Next slide. Prevalence is going up. So this shows in green people with a mental health disorder, and in blue people without a mental health disorder. So there's a difference. There's a pretty major difference in terms of percent of people impacted in any given time. The previous numbers were lifetime incidents. So here you see less than 0.5% of people in the general population, but 2.5% of those with a psychiatric illness had cannabis use disorder back in 2005. But they're actually diverging, where the rate of rise is higher amongst those with psychiatric illness than amongst those without. So it's a major problem, and it's a current problem, and it's getting worse in some ways. Next slide, please. And here we see that essentially even in people without a cannabis use disorder, it's more prevalent in those with major depressive disorder or suicidal ideation, if you will. So essentially, cannabis use disorder, you see non-use at 10% across both those with suicidal ideation and with depression. But cannabis use disorder or non-disordered use is higher amongst those with major depressive disorder than those without, and then cannabis use disorder is much higher amongst those with these psychiatric challenges than those without. Next slide, please. Here we wanted to have a look. A lot of us are bombarded a bit by sort of popular media, sort of advertising cannabis for sort of so many things that it almost seems magic, if you will. And here we did a randomized controlled trial of people who were seeking cannabis but hadn't started using it on a regular basis for either depression or anxiety, or insomnia, or pain. And granted, there's a lot of comorbidity even amongst those, but what was the main reason people were seeking cannabis? And folks who volunteered for this were randomized to either go ahead and get a marijuana card back when you needed one, or to wait, to basically agree to not use for 12 weeks. And what you see, this was done by led by Jody Gilman in our group, whose photo is here, fantastic researcher here. And what you see in the first curve is with the dark round circles, those who were assigned to go ahead and get their cannabis card right away increased their use to about every other day, and those who were supposed to wait generally waited, and they were using less than a half a time per week on average. What we saw that's not on this slide is pain and depression, anxiety did not get better at all. They just stayed flat. Insomnia got a little better. But what was striking here, and that I really want to take home, is that on the right side of the slide, this is new onset cannabis use disorder. So you couldn't have cannabis use disorder and come in this trial. And if you came in and you had pain, not a low risk condition, there was really not a big increase in cannabis use disorder. If you had insomnia, same thing. It was not a big increase. But if you had depression or anxiety, and that's what you were seeking cannabis for, by 12 weeks, so within 3 months, we had nearly a 20% incidence of cannabis use disorder, right? So this is just highlighting, we want to think about the benefits of sort of, or the potential benefits of using substances, as in this case, cannabis, but also the downsides. Next slide. Thanks. So this is these are data from a school-wide survey across Massachusetts. So this is in about 15,000 kids that were surveyed in 2023, where we wanted to look at substance use and psychiatric symptoms. You know, there's the kids we talk to, they use language like, oh, cannabis use is part of a healthy lifestyle, and so we wanted to sort of have a look at that. And what we found was that the more frequently you use, from never to even ever, to monthly, weekly, or near daily, with increasing frequency, we saw increasing severity of psychiatric symptoms. So just shown here is suicidal thoughts. And this is a measure of anxiety and depression, the PHQ-4. What's not shown here are two other scales which looked exactly the same. One was for attention symptoms or ADHD symptoms, and the others for psychotic experiences. So the more frequently you used, the more the cannabis, the more frequently you had those symptoms. And so my colleagues were very exercised that, oh my gosh, this looks like potentially causal, you know, maybe the cannabis is causing this. And I said, well, show me alcohol and tobacco. Next slide. Exactly the same. So it almost didn't matter which substance you were using. The more frequently you use, the more severe their psychiatric challenges. So here is suicidal thoughts, and here again is anxiety and depression. And while it looks like alcohol is an outlier here, it's not. If you were a daily user of alcohol, you were very likely to be a daily user of cannabis and nicotine. So this is just a sort of an artifact of the way we gathered we sort of coded the data. Next slide. And this shows that, I don't know if my pointer shows up, but if you look at alcohol all the way to the daily side, you see most of it is light blue, and that shows poly use. So basically poly use across substances is super common, right? And associated with psychiatric symptoms. So I showed you that subsyndromal cannabis use is more common amongst those with suicidal ideation or depression. And here I'm showing you frequent use of alcohol, tobacco, or cannabis is associated with essentially subsyndromal psychiatric symptoms in young people. Next slide. And next slide, yep. So this gets to tobacco. You know, we know that tobacco kills half its users. It's the only consumer product actually to kill half its users when used as directed. And those with psychiatric illness bear a much higher burden of a tobacco use disorder. So 15%, so threefold more people with bipolar disorder smoke than in the general population. And, you know, fivefold or more those with schizophrenia spectrum illnesses smoke than those in the general population. And the mortality is enormous. So those with serious mental illness have a 20 to 25-year mortality gap due to tobacco-related illnesses. Okay, and so so this is my plug for our program and for attempting to quit smoking. People with serious mental illness can absolutely quit smoking, and quitting smoking reduces your risk. So that's the situation. But those with serious mental illness, we know are very affected by this comorbidity or co-occurring substance use disorder. And here with a major impact even on lifespan. Next slide. And here's the impact of cannabis use. This is a particularly striking study to me, just showing the massive impact of cannabis use on essentially the course of illness for those with schizophrenia. This is from Scandinavia. Out of about 50,000 people joining the military, 400 developed schizophrenia. And those who on a questionnaire had used cannabis before they enlisted, right? So before age 18 to 20, and they enlisted in the military at age 21, over in the coming years, they had twice as long of a first hospital stay, nearly 60 days versus 30. They had more than twice the number of hospitalizations sort of on average. They had more than twice the total number of hospital days. and they had threefold higher odds of having more than 20 hospitalizations. And this is adjusted for other drug use, risky alcohol use, family factors, and environment. So it's just a massive impact. So you know, as I'm giving this talk to the people at the National Institutes of Health, et cetera, I'm urging them to study this phenomenon, please. Next slide. Because this term dual diagnosis, which we don't really use quite so much anymore because it's become practically synonymous with having a difficult course of illness, right? And the prognosis over decades can be impacted. Just last year, Nora Volkow, who runs the National Institutes on Drug Abuse, published a paper, I think it was in JAMA Psychiatry, showing that up to 30% of the risk for schizophrenia in males is potentially attributable to cannabis use. So in other words, potentially preventable. And in fact, in first episode programs around the country, we now actively look for siblings of those who have a first break in schizophrenia and actively advise them to not use cannabis. The same thing for say people, adolescents with bipolar disorder. We actively tell them that they really can't experiment with alcohol. We say, you know, it's not fair. Your friends are experimenting with alcohol, but you have a much higher risk of becoming alcohol, you know, developing an alcohol use disorder. And so, but this dual diagnosis term, or this assumption that the course is going to be worse, is one reason that, say, pharmaceutical companies and even investigators may want to exclude them from trials, or even NIH, because they may not do as well on a treatment. And my argument is, well, we need to know that because it's just so common. And that people who have both challenges are precisely who we need to study in order to make the big leaps in progress in therapeutics that we want to see for folks, right? So what I have been trying to really, you know, convince people is that people with both disorders can be included in trials with good results. They can stay in, and we can get a sense for having what having another diagnosis does for treatment response, right? We need multidisciplinary research teams, perhaps bringing the experience and expertise from the psychiatry or psychiatric standpoint and the substance use disorder assessment and treatment if needed. But this is challenged by sort of our clinical silos and cultural silos, right? Because due to historical sort of regulatory practices, you know, Department of Public Health regulates substance use disorder programs, and the Department of Mental Health tends to be involved in community mental health centers and psychiatric treatment. Training is separate as well, all too separate, although we're trying to include more substance use disorder training in residencies as opposed to waiting for people who go to a fellowship to get their training. Next slide, please. So people with commonly co-occurring psychiatric and substance use disorders are enrolled into virtually all large treatment trials. True or false? You can click the slide. There should be a little, oh, never mind. Go back, please. Sorry about that. So the answer to that is false. That I thought that would be a little animated. And as an example is this trial of a medication I'm actually quite excited about. And I actually served as the head of the Data Safety Monitoring Board for this trial. But this trial just was extremely strict in its exclusion of people with any substance use disorder or even any substance use. If you had any cannabis use, for example, you had to get special permission to come into this trial. And so therefore you're going to know that this drug works, but you're not going to know how it works in people, the most common people who are out there, people who have some challenges from both. Next slide, please. You could click it again and again and again. And so here we've got an entire FDA program which approved a medication for treatment of tobacco use disorder, but it excluded the largest group of smokers in this country, people who smoke who have a psychiatric or substance use disorder. So when we had problems with the varenicline, when there were some psychiatric side effects amongst people taking it, we had no placebo-controlled data to help us understand these adverse effects. And there was a bit of a panic. The FDA put a boxed warning on the medication, and we essentially blamed the medication for the side effect that we're seeing in people who took this medicine with a psychiatric comorbidity. And it wasn't until the EAGLES trial, when we enrolled large numbers of people with depression, anxiety, or schizophrenia spectrum disorders, and we saw that actually the adverse event rate with varenicline is absolutely no different to the adverse event rate with placebo. In fact, it was just essentially what was going to be seen with the medication. And it's taken us years to sort of come back from that. And so I think, there had been this lore that people with psychiatric illness couldn't quit smoking. And so I think people really just didn't bat an eye when they were excluded from these trials. There was no outcry. And the whole idea that varenicline makes people suicidal sort of became entrenched clinical lore, alongside the prejudicial lore that people with psychiatric illnesses can't quit smoking. Varenicline got its own SNL skit that it essentially makes your brain explode. Google it, it's on YouTube, just SNL Shantix. And the resulting boxed warnings in the United States and Europe did real harm because they dramatically cut its use as a treatment. And so people didn't get the treatment that they needed. And they didn't quit smoking, for sort of 15 years. We could be now seeing the mortality rate from smoking-related illnesses come down and people with psychiatric illness, and that mortality gap come down if we hadn't had that reduction in use of the most effective medication. And so really the FDA allowed that to happen by allowing the trials, the registration trials, to exclude people with psychiatric illnesses. And I think we're going to do this. And I take heart remembering a generation ago, it was rare for women to be enrolled into clinical trials because we were too biologically complex, right? But funders played an invaluable role in ensuring inclusion of women into clinical trials, or requiring very strong scientific justification for not doing so. And so my goal really is to urge regulatory agencies and funders to help us move in a similar direction for people with co-occurring disorders, so that we understand the treatments that work and get them the best treatment, provide the best treatment that's possible. Next slide. So this FDA mandated EAGLES trial stands out to me as a great example of one approach. This trial studied a substance use disorder treatment. This was varenicline, and actually varenicline, bupropion, nicotine replacement therapy, and placebo in the general population, alongside well-defined samples with co-occurring mental health diagnoses. And here you see on the far left, the side effects amongst those without a psychiatric illness, with varenicline in blue, bupropion in green, nicotine patch in purple, and placebo in gray. So you see it's not different. And then if you look in the middle, the side effects during treatment or 4 weeks after were a bit higher amongst those with a psychotic disorder, right? About 3-fold higher, but it didn't matter what medicine you were on. And then if you look all the way to disorders, the same thing. So if you have a psychiatric illness, you're more likely to have some kind of neuropsychiatric adverse event while you're trying to quit smoking or in the month after. But if you show the next slide, these medications that aren't different on safety, and just click through, you'll see they work better for efficacy, right? So in the psychiatric, not in those without a psychiatric illness, varenicline is better than bupropion or nicotine patch, and all three are better than placebo. And it's the same thing for psychotic disorders and mood disorders, right? So these medications work, and with this huge, very expensive trial, we see that that they're safe. Next slide. And so with these safety data, the FDA and also the European Medicines Association removed box warnings for varenicline and bupropion that were a huge barrier to treatment. And implementation trials that I'm doing with Dr. Cather and others are now trying to undo the damage and get these effective treatments delivered to the community. There's a lot of prejudice and fear about these medications because there's a lot of hype about something that in the end turned out to be incorrect. And as I mentioned, had people with mental health disorders been included in varenicline registration trials in the early 2000s, I think we would now be seeing smoking-related mortality in these populations starting to come down roughly 20 years after FDA approval. And just there are so many other needed trials. I would love to see an antipsychotic study in people with schizophrenia and cannabis use disorder. So to have both, as they come in the door. Such a treatment that improves both could impact clinical outcomes, treatment utilization, cost, and mainly people's lives. Next slide, please. So our clinical experience at the Freedom Trail Clinic here at MGH that relapse happened quickly led us to propose a maintenance treatment trial showing that those with serious mental illness, here it's primarily schizophrenia spectrum disorder, some bipolar disorder, who got maintenance pharmacotherapy were able to triple their abstinence rate at 1 year. And this led MassHealth to make 12 months treatment with varenicline available to those with serious mental illness with just one prior approval at 6 months. But again, this study set out to study people with a serious mental illness and tobacco use disorder, right? And so to understand, is there something special about treatment with this group of people that we need to know so that we can best inform them and they can make their best informed decisions for themselves. Next slide, please. And this study is one I did with Corey Cather and our friend and colleague Gail Daum at Johns Hopkins, where we worked with people who with serious mental illness who were ready to quit right away or not yet. So this is a trial where we made 18 months of treatment available, and we showed that those who weren't ready to quit right away, if we encouraged them to start treatment, they were able to quit as well, quit smoking as well, to have success over those 18 months. And as you can see, if you want to go back one real quick, what you can see is that basically if we offer treatments over 18 months, the abstinence rate goes up month by month by month. So every month of just offering active treatment, encouraging people to stay on treatment, and and experiment with reducing or quitting, and if they slip, stay on treatment and try again, that the abstinence rate just went up and up and up with continued availability of treatment, whether you are ready to quit or not right away or not at the beginning of the study. So again, enrolling people at the outset with two disorders and looking at how treatment works in that special population. Next slide. So the desire for conservative models amongst scientists and clean populations, which I hate even that word, is super strong because people want, in their study, they want good results, they want clear results, and sort of simple designs, in the end is kind of is one way of defining good science, because complexity can complicate interpretation. But the problem is the purity in enrollment criteria yields data that aren't generalizable to potentially half the population that we're trying to work with, right? So I think further, and even more importantly, maybe we'd get better treatments for people with co-occurring disorders if we tested treatments in co-occurring disorders. It's not too much of a leap, I think. Next slide, please. So essentially, this is just examples of a complexity, right? There's so many forms of complexity in co-occurring disorders just in clinical trial inclusion, and we'll have to work that out, right? So does co-occurrence mean at the same time or over a lifetime? Does it mean you had pre-existing, but it's resolved? So in the Eagles trial, we had people with pre-existing substance use disorder, but it couldn't be current. You know, is the substance use are the symptoms substance induced? Many alcohol use disorder researchers think that, okay, if you get the alcohol use disorder under control, the depressive symptoms will be under control, or go away. And even within diagnoses themselves, there'll be variability in pathophysiology. And of course, many people thought not to have a co-occurring disorder in their 20s will have subsyndromal symptoms or unrecognized symptoms, or haven't yet manifest a co-occurring disorder. Like for people that may have had several depressive episodes, and they don't know that they have bipolar disorder because they haven't had a manic episode yet, but they do have that. So there's just complexity, but I think we can do that. There's some wonderful examples of people tackling complexity head on that I think illuminate opportunities. And warning, the next slide, super complicated, but I'll walk you through it. Next slide, please. I'm almost done, just a couple more slides, but in this study, I love this visualization because it shows really complicated things. So in this wheel, the concentric circles represent diagnoses. From the outside in, the circles represent substance use disorders, the farthest out, and then bipolar, and then neurocognitive, and then schizophrenia, and then depressive disorders, etc. And the dots represent individual symptoms. So a spoke that goes through, of dots that go through the different concentric circles represent symptom repetition across diagnoses. And what you'll notice is these spokes have lots of dots on them. And that means there are multiple diagnoses for which a single symptom is an important symptom. And so from 12 o'clock, if you go counterclockwise, we see individual symptoms present across 8 different diagnoses pretty often, right? And this preprint by Miriam Forbes provocatively even says, maybe major depressive disorder isn't even a separate syndrome, given the symptom overlap with substance use disorders and other diagnoses, because almost no symptom of major depressive disorder is not also a symptom of another DSM disorder, and many co-occur within 7. Okay, so to me, this underscores our need for biomarkers. Of course, she thinks that MDD is a separate diagnosis, but we need biomarkers. And the concept of co-occurring disorders exists more fundamentally sort of at the symptom level. And this obviously motivated the RDoC framework to organize study of more fundamental processes across diagnoses to help us get to this genetic or cellular or circuit level. And really one more data slide. Next slide, please. This is a reprint from Tom McCoy, who's a colleague of ours here in the Department of Psychiatry, who's a big data guy. And he went through into the electronic medical records and looked for genetic hits with diagnoses, okay? And he found nothing, only noise. So he, not being one to give up easily, he used natural language processing of symptoms recorded just in the notes, the clinical notes. And doing that, he identified hits for people with social symptoms in the social realm, in the cognitive realm, and in sort of the arousal or agitation, anxiety realm, showing that sort of our diagnostic categories might not be necessarily the best to translate down to the biological level, the genetic level. And polygenic risk scores are another opportunity that have been useful. One last slide, please. The next slide. Here is a study, and this is not a substance. This is only substance use, and this is in animals. But essentially, it's another tool. Animal models are another tool that I think can help us to increasingly elegantly model the complexity of the common clinical situation. And here, they were testing the gateway drug hypothesis, and animals that were exposed to nicotine for 2 weeks before they were exposed to cocaine became addicted to cocaine much faster at every level from left to right. It's histone, like basically DNA unwrapping, and then immediate early gene expression, and then long-term potentiation, attenuation, and behavioral sensitization. These are different ways of measuring the onset of addiction, and they happen faster and earlier in the animals that got nicotine first. So it's a complex situation. We've been essentially arguing about the gateway drug hypothesis for a generation, and here with a pretty simple, elegant, kind of brilliant experimental design, they showed that there is a gateway drug phenomenon. It's more called neurobiologic priming than gateway, but essentially you prime the brain to become addicted to cocaine if you pre-expose it to nicotine. So I'm just going to put this slide up, and be happy to begin to take questions. It sort of starts to ask, like, why can't we get to, what's been the barrier to studying comorbidity in clinical and preclinical addiction and mental health research and basic neuroscience? Is it stigma? And then the next slide, please, and which is my last slide. Just sort of help us understand some of the barriers to doing this work. That would be fantastic. So I don't quite know how the question and answer works, but
Yep, I'm gonna help you. Eden, beautiful, masterful job. You're such a wonderful teacher, and you take complex things and make them very understandable. And also you get our blood up and get us kind of fired up to take action. So a lot of great questions have come in. Let me ask you this one. Is there research on the comparative long-term safety and efficacy of using psychiatric medications that are regulated versus using cannabis or tobacco for symptoms of depression and anxiety?
Gosh, well, there's really no long-term safety data on cannabis or tobacco for depressive symptoms. In fact, we think there's good biologic reason to think that cannabis will make depression worse. In our study, we found that it didn't change depressive symptoms, so it certainly didn't improve depressive symptoms. But many people, when they were using cannabis from the dispensaries, did not get in their body what they thought and what it said on the label. So it says to me that there's a problem with the regulation of the dispensary cannabis. So anyway, but there's no long-term data, and so there's lots of long-term data on treatments with proven efficacy for depression. So there are lots of choices, and they're wonderful sort of newer choices as well, including ketamine, S-ketamine. The psychedelics will be coming, but certainly TMS, rTMS, which is being really, I think, perfected here in Boston with Juan Camperdan doing repeated TMS, and ECT. So we have wonderful treatments for depression, and so going to treatments without a proven track record, and certainly with good reason to think they were going to worsen things, would be, I think, potentially tragic. Certainly not recommended.
Fantastic. Another person wanted to hear some comments about other forms of nicotine, such as Zins, vaping, etc. Implications for treatments when people are not using combustible tobacco, but they're using these other alternative forms of nicotine.
Sure. So these are not safe forms of nicotine. They're certainly less harmful than smoked tobacco. And smoked tobacco does make you metabolize many psychiatric medications more quickly. So therefore you need higher doses. And that can be really problematic in managing your medication. So Zins or electronic cigarettes do not cause that problem. They are certainly highly addictive, but they're not going to interfere with the medication, your medication metabolism if you're on an antidepressant or an antipsychotic or a mood stabilizer that's metabolized by the liver enzymes that are sort of revved up by tobacco smoking. But these are addictive, and they may make other addictive drugs more rewarding. And the place where we really try to help to prevent use or help with cessation is amongst adolescents, because these are the people who are really have their a whole lifetime to potentially become addicted to another substance, and their brains are far more malleable to addictive substances. So, was there a specific question about Zins and e-cigarettes? Just general.
A bit about sort of the method, the different absorption, and I think they were alluding to the question of safety of something like a Zyn versus a vape versus smoked tobacco.
Yeah, we don't know. We're learning a bit more about vapes. They're not harmless, but they're certainly less harmful than smoked tobacco, and Zins may be less harmful than electronic cigarettes, which do cause some airway reactivity, cause some airway symptoms. We're just trying to learn that. I'm working with a group in Minnesota who have some pretty compelling results that we will work with more, but certainly looks like there are harms amongst from e-cigarettes that aren't there for non-smokers and former smokers that go straight to no tobacco. But we don't know yet for Zins.
And how about one last question, just because we have so many good ones. You talked a little bit about this, but just could you talk a little bit more about the relationship between cannabis use and psychotic symptoms and psychotic disorder, and if there's anything known about its relationship with bipolar disorder?
It's much more known about schizophrenia. It appears to me to meet all the criteria, from causal inference to be considered a causal contributor to schizophrenia. Okay, which means that if you don't use it as an adolescent, you may be able to prevent onset of schizophrenia. So this is huge, especially as we know that these disorders have a high genetic component. Letting the next generation know that they really can't afford to experiment with cannabis is important. Because these are all, we can't do a randomized control trial of cannabis exposure to people at risk for schizophrenia. We can't do a prospective trial. These are all retrospective epidemiologic with the problems that entail, but it's been replicated sort of 5 or 6 times with a big odds ratio. So I'm quite confident that there's a causal component. And what's very clear is that that cannabis use throughout the course of a psychotic illness, of a schizophrenia spectrum disorder, worsens the course. It's a big effect, and so not using cannabis I can make that recommendation with high confidence that will improve people's course of illness. It's not going to make you symptom free, but if you people who continue to use cannabis will almost just with a high confidence have a worse course of illness.
Thank you so much. It was really wonderful.
Pleasure.
It's a pleasure now to introduce 3 remarkable individuals who will be talking about dual recovery through the lens of their unique professional and personal experiences. First, we'd like to introduce Val Comerford, who is the Director of Recovery and Employment for the Massachusetts Department of Mental Health, Central Massachusetts Division. Val is a certified peer specialist and forensic peer specialist with a 30-year history of experience in the mental health and recovery community. Val was an early pioneer who championed the start of Dual Recovery Anonymous in Massachusetts. In 2019, Val, along with one of her colleagues, started the Dual Recovery Collaborative, which brings together providers and people in services across the state from both DMH and DPH, forging new relationships and tearing down silos that have traditionally separated recovery spaces.
Our next panelist, Celeste Maria Isabel Clark, is the Director of Recovery and Employment Services for the Department of Mental Health, Western Massachusetts Division. She is a certified peer specialist and a trained facilitator in hearing voices, alternatives to suicide, and intentional peer support approaches. She's been a leader in thinking about relevant, acceptable, and effective models of peer supervision and participated in the development of the 2022 Guidelines for Supervision of Peer Supporters in Massachusetts Adult Community Clinical Services, as well as co-chairing the joint Western and Central Massachusetts Peer Support Supervision Guidelines Implementation Work Group, both in collaboration with iSpark from UMass Chan Medical School.
Scott Francis is our third panelist member. Scott is also known as Sunshine Scotty, and he began working as a certified peer specialist in 2006 and a certified wellness recovery action plan or RAP facilitator in 2011. He lives his RAP every day. He became a BSAS recovery coach trainer in 2018 and graduated from the BSAS facilitator mentor program in 2020. His dedication and love for facilitating trainings for Massachusetts Organization for Addiction Recovery are obvious to all who have had the tremendous pleasure of hearing him say 3 impassioned words: recovery is real. He is an ardent advocate to enhance access, inclusion, and equity for all human beings to live a life that matters. It is our great pleasure to have the panelists here with us today. Thank you.
Thank you very much. Thank you for those wonderful introductions. I have the privilege of being the moderator today and working with 2 very special colleagues. I wanted to start by just prefacing that we each come here today with a different lived experience. We've had different trainings made available to us over the years, and we also work in different roles. But we have shared values, and those shared values begin with self-determination, mutuality, dignity and respect, a lifelong learning of personal growth, and peer-to-peer support. I'm going to be asking some questions of both Scotty and Celeste, and they'll be going back and forth and helping each other to answer these questions. But the first question that I'm going to ask is to Scotty. So Scotty, can you share some of the similarities and differences between CPS, Certified Peer Specialists, and recovery coaches?
Thank you, Val. Both of them, I'm a, certified peer specialist since August of 2006, and I've been a BSAS recovery coach trainer for a while, and both of them really seek to inspire hope, to help people get in touch with their inner wisdom. I love that quote from Parker J. Palmer: "The answer to life's most difficult questions are found from within." So both roles seek to treat people as resources, seek to see people as experts at themselves, and to support not only self-advocacy, but self-efficacy. We want to help people to believe in themselves, to use their strengths. Both roles are strength-based. The recovery coach training uses tools like Recovery Capital, where we take a look at our internal resources, our external resources, to maximize and grow that recovery capital to go after our hopes and dreams. Same thing CPS does. We also want to share our lived experience to inspire hope, to role model recovery, to act with integrity. The CCA is the training that is used predominantly throughout recovery coaching, divided down in Connecticut, and they have ethical considerations. CPS training has a CPS code of ethics. And so we want to be able to, both roles seek to do no harm and to maximize the impact of, the support And both roles seek to support people to do wellness planning. The tool I love, which is I'm going to just say I never learned about WRAP, Wellness Recovery Action Planning, in all my years of, I came into this recovery through the mental health door. And back in 1995, and no one ever talked about wellness. It was always, viewed through the lens of illness, and no one ever told me I was an expert on myself. So if you're here today, you are an expert on yourself. You can get well, you can stay well, and there are no limits to recovery. So that is some of the, and also I just want to say, as far as coming into that door about into recovery, I lost a job in 1994 because I went to the World Cup soccer match and showed up with alcohol in my breath the next day, and then I went through a period of sadness because I felt bad, like I got fired, and then I went back to school and felt better about myself. But I ended up with a diagnosis of a bipolar disorder, and no one ever asked me about my trauma. No one ever asked me about my substance use. And it wasn't until I went to the CPS training where I got some peer support and began to heal from some of that trauma. And I think this is what both trainings seek to do, is help people heal from trauma and learn new tools to go after what they want. Once I was able to get some support and take a look at how I was coping with my recovery, and to realize that, I was dealing with my feelings, with my trauma through using substances, and I was didn't have the supports to be able to make some changes. So finally, by taking a look at that stuff, I was able to enter into addiction recovery and then connect with a whole another group of community for my wellness. And also, you like pictures? I'll give you an example. This is what I look like coming in. Can you see this?
Yes.
That's what I look like as a result with my support through the mental health system. I was given medication, tons of it. And then like a bunch of years later, I was given peer support and I was able to develop a wellness plan. I mean, which picture looks better, everybody? Come on now. I don't know if you can see. Oh, yeah, Kenny, I don't want to show this other picture. All right. And so like having that support, and be able to realize, what? There are multiple pathways of recovery. And that Wellness Recovery Action Plan became my baseline to going out and seeking different ways for, to be well. In fact, that's what also the BSAT, the trainings for recovery coach, is support multiple pathways of recovery. So it's not just AA and NA, it's DRA. And Val, she's kind of modest, but she's founded the first DRA meeting in Massachusetts. And my personal favorite, Fridays at 4 online. So, the recovery coaching supports, just like CPS's, multiple pathways of recovery. And also, we recognize that this recovery process isn't always going to be a straight line. We can have ups and we can have downs. And both trainings seek to reframe their people's experiences as learning experiences, and that we're building recovery capital. We're developing new knowledge. So by
Scotty, I have a question for you.
Yes, thank you.
I have a question for you, and then we'll move on to Celeste. For the audience, please explain what recovery capital is for those who don't know.
Okay, it's the internal and stuff we have. It could be knowledge. It could have emotional intelligence. It could be our own personal resiliency. It can be hope, and it also can be the external capital we possess. Like maybe right now, look at the recovery capital I have. I'm coming from you from a home. Check out this suit. This is recovery capital. How do I look in everybody, huh? And my wife didn't even dress me today. That was part of my internal recovery capital. I could pick out my own clothes. And anyways, it can be a job. It can be the people we know in the community. It could be a gym membership. It can be a car. It could be a T-Pass. It can be being part of a recovery center. I am part of like all these different BSAS funded recovery support centers. We have like almost 40 of them around the state. I'm also still have my membership at the RLCs that are funded by DMH. So those relationships in the community and information that we know. Did I answer your question fully, Val?
Yes, thank you very much, Scotty.
Recovery is real, my friends.
We'll have all of these resources available at the end of our panel, some of the things that we're talking about today. Celeste, you're up next, please.
Sounds good. Thank you, Val. And thank you, Scotty, for sharing one of those foundational peer support practices, which is always to share where you're coming from, and that where you're coming from being so informed with where you've been. So for me, one of the things that I'd say is one of my primary interests is sort of seeing how peer support fits in within sort of existing institutional practice. So for me, I'd love to approach the question of what are some of the similarities and what are some of the differences between certified peer specialists and recovery coach roles, sort of as revealed by some of the shared tensions that they produce as peer support practices within fundamentally clinical systems. So there is an organic tension between peer support practices, which certified peer specialists and recovery coaches both engage in some ways straight from the name and straight from the grounding values. Peer-to-peer approaches, for example, all people receiving services as equals, as opposed to approaching people receiving services as people that they are serving, as clients, as patients, as other ways or other language which sort of suggests a different relationship and a different relationship dynamic. Inherently, from an organizational perspective, that can cause some friction. For example, the space and ways in which peer support practice is really allowed and needs to engage with the people participating in can really butt heads and offer something quite different than what the professional expectations are for clinicians. You can take one common sort of example in terms of the space for expressed unacceptable feelings like suicidal ideation, which often, right, is present actively, if not unspokenly, in folks who are presenting with some struggles around substance misuse. In peer support practice, that does not sort of clock in any sort of mandated reporting, that does not clock in an emergency intervention, that does not clock in an involuntary sectioning, either a section 12, which would be in the mental health land, as I like to call it, or section 35, which would be in Department of Public Health land. So I assume that sort of illustrates, for example, how the values-based practice of sort of these multidisciplinary teams can differ and can open up some tensions. And this is true both for, I believe, recovery coaches and for certified peer specialists. Philosophically, I think that kind of surfaces a similar tension in both lands in terms of how we approach the right to self-determination versus public safety, a framework that believes in recovery and a framework that is based in a medical model or illness, how we approach appropriate practice by prioritizing either for human rights and issues such as guardianship. So for me, some of the deepest similarities between certified peer specialists and recovery coach roles in these two separate silos is actually organically what those peer support values and practice bring up as tension points within organizational practice. Organizational practice all the way from how you interact with the people that you're supporting and what you get, perhaps, or who you get in that interaction, to what is considered an appropriate approach. One significant difference, though, that I would say in terms of certified peer specialists and recovery coaches is the stigma around the possibility of recovery, and perhaps even what that means. When talking, in regards to substance misuse, it is sort of as a baseline assumed that it is possible to recover and that from substance use, and that the recovery process is a movement towards complete abstinence. Whereas when I tell people that my title is Director of Recovery within a mental health context, it can be kind of a provocative sort of statement to suggest that recovery from mental illness is possible. There's an inherent difference in response, and in value that kind of really surfaces, again, for me, what is one of the primary differences. And then you see sort of that primary difference in belief in recovery and what that means, also reflected in how organizational practice or institutions attempt to integrate or work with their peer support practices. That's it. That's my answer.
If I may add, Celeste,
Please go ahead.
I agree 100%. A few years ago, I was speaking to a group of psychiatrist residents at a hospital in Boston that I will not name, and shared my mental health recovery story. And when I was done, like I always say, recovery is real. I'll say it all the time. And somebody asked me, one of the residents, are you saying that recovery is real from a mental health condition? And I could not believe it. I also had a boss who didn't believe me when I told her, like, I will tell you if I'm not well. She said, well, how will you know? I said, I have a wellness recovery action plan. I know what I look like when I'm well, when I'm not well. And, so some people just do not know that people can get well and stay well. And that's what I love about the ethics and values of RAP. So thank you, Celeste, for sharing that.
I'd like to explore a little bit more, since we have time, what more of those tensions might be between the two different worlds. Celeste or Scott?
Sorry, Val, I'm not entirely sure
I got you.
approach your question.
I think I'm going to tell you right now. I got you, Val. There is prejudice and discrimination in the world, okay? And there are people who are prejudiced against people in mental health recovery, and also people who have prejudice and discriminate with people in addiction recovery. It can be the lens that people look through. For instance, I've been trying to support DRA initiatives at recovery centers, and so not everybody sees themselves as somebody who could benefit from DRA. There is a little bit of, I think, stigmatization.
What is DRA again, Scott?
Dual Recovery Anonymous.
Thank you very much.
Because I think, and also one of the things that as a recovery coach trainer, I teach mental wellness trainings. And so we have recovery coaches who go through that and who they don't not understand what Celeste was just making a point, that people can get well from recovery. There is stigma. There's a great video out there if anybody wants to look at it. It's a social experience around mental health language in, I believe it's Singapore. And it's just people's viewpoints on how people see people who've experienced a mental health diagnosis, and they could look at them as less than. So there is that. And when people don't understand what people have experienced, and people might use words, and also a lot of this stuff can be unintended harm. The language, calling someone crazy, referring to somebody by their diagnoses, in both sides of the aisle, calling somebody an addict. Well, are they an addict, or are they a person in recovery? So we don't want to dehumanize people through language. We want to use humanizing language that's strength-based, that supports self-efficacy and the belief that people can learn and people can change and people can grow. So when there's a lack of understanding and also intimate relationships from who are people from their different, like talk about cross-cultural partnering. Like when we meet new people who have different experiences and we develop a closeness, we can understand what they are, what their belief system is, their values, and then we can have conversations to learn, and we can both grow. Hope I answered your question. Celeste, you want to follow up to that, or do we move on to the next question, Val?
No, thank you, Scotty. Actually, that was a little bit of the extra framing that I could really benefit from in terms of exploring a little bit more of those differences as it relates to tension. I do think that the particular flavor of stigma in sort of the substance use land of people who have struggled, who are in recovery, and the stigma in mental health land of people who have been diagnosed with especially some heavy duty hitting psychiatric diagnoses completely changes actually some of the, in some ways, I feel like some of the role potential between recovery coaches versus certified peer specialists. It changes some of the invitations to participate and to what capacity in terms of, for example, I don't know, treatment and sort of heavier duty decisions in sort of regarding substance use treatment versus a treatment towards recovery from in mental health. I also think that it's part of that unavoidable tension, and that difference in response along stigma is that one that almost tends to locate the source of, if you will, the problem or the issue in an external substance that is sort of being consumed by an individual, and the other, specifically as is revealed in the way, the language that we use to speak about folks in the mental health system within the individual. And that makes a huge difference of what that means in terms of the possibility of that relationship really between the person providing services and the person receiving services, and what the imagined potential over the lifetime is of that person, not only from in terms of what the provider imagines as possible and sees as potential, but also what the person receiving those services sees as possible and in potential, for themselves.
Good catch, both of you. Thank you for going exactly where I wanted you to go. And before we go to the next question, only because I have an opportunity, we've used the word stigma. And over the last several years, and I invite you to join me, I've replaced the word stigma with what it feels like to a woman who is in dual recovery. And it feels like discrimination. If I go to a mental health provider for support, and they want to restrict what they can provide to me based on my substance use history, that's discrimination. If I go to a substance use provider and I try to get support for my substance use, and they want to restrict what they can provide based on my mental health history, that's discrimination. So I invite you all to throw away the word stigma and join me in using discrimination, which changes everything. It changes every relationship you'll have from now moving forward if you get rid of stigma and replace it with discrimination. And we're right on time now for our second question. So the second question, and we're going to lead with you, Celeste. What is the potential of peer support roles to work with and in between these two worlds, distinct service sectors? You want me to read it once more? You got it.
I got it. I think I'm good. Thank you, though, Val. It's hard to let go, actually, of how meaty the last statement that you mentioned was, what it means to rephrase stigma as discrimination. I admit I'm having a hard time letting that go, because I could just dig right into that. And for me, for example, when I see that 20-year gap in terms of life expectancy with my people, with the population that I belong to, one of the first things that comes into my head is what the experience of receiving healthcare in a doctor's office when you have a rap sheet of psychiatric diagnoses is like. And also what that means when introduction in a long time in the system suggests about the quality of your social supports, and then what the quality of your social supports mean or tend to, in terms of helping to advocate for oneself, especially when it comes to such a massive power difference, you know, like in a health space. But I will say no more of that. So in terms of the second question, what do I see as the potential of peer support roles to work with and in between these two distinct service silos? For me, I still kind of think that it's that tension in peer support roles that define its potential. When it comes to peer support within institutional settings, the tension is good. You want the tension. It is precisely when something doesn't fit, when there is an opposing and challenging framework that's coming to bear on a decision of where do we go from here and what do we do next, that we can really talk about, you know, figuring out some innovative solutions, that we can really expand the potential for growth in terms of what's our repertoire for how we move forward in support of an individual, of a person. So for me, the tension is good. And it is actually what defines what makes peer support roles so well suited to sort of this in-between space. I think if I were to think of or consider some concrete examples in terms of that, is one of the tensions in peer support roles within institutional settings is what is considered part of treatment towards recovery. Organizationally, right? That can look like what do we consider a professional use of our time? What do we consider good supports for people? Do we incorporate, I don't know, highly individualized sort of goals, personal goals into what goes right into treatment plans? Things like a role or multiple roles that can support a person to take them to Planet Fitness, or other working out, to learning to play an instrument, to encourage them even to play that instrument in for others in a public setting. Things that make life good, but that are generally not considered critical, fundamental pieces of training. Peer support role, given that so much of its definition is forming a genuine connection and then supporting that person to find their own path through what makes life good for them, what makes life meaningful for them, involves actually suggests a massive increase in the flexibility of what we consider possible use of time for that role. Another part of the tension, which I think shows some of the potential, is that peer support roles don't carry things like assessments. So the nature and flavor of a conversation, what you can glean in terms of information about where a person is, what they're engaging in, what they're feeling. Sometimes, depending on the quality of that peer-to-peer support relationship, the level of quote-unquote unacceptable feelings that are shared, you know, within that relationship is totally different. And knowledge and access, privileged access to that kind of information is, I mean, talk about, I guess, preventative. Talk about getting a individualized intervention. And because, peer support roles don't need to or shouldn't be submitting assessments, be submitting case notes, be engaging in risk mitigation plans, the possibility really for the kinds of conversations and exchange that happen within that relationship are just vastly different. And vastly different amounts of information mean vastly different possibilities for action. I guess another place in which that tension is good and is shared is is what is considered an appropriate relationship to risk. So how these tensions, right, like desire to use again, proximity to maybe using again, wanting to, thinking about self-harming behaviors, wanting to engaging in self-harming behaviors, all of these quote unquote unacceptable feelings, right? That for the most part, people do not tend to disclose very, in an assessment format, and which constitute risk, are renegotiated within these peer support roles. Some of the ways from an organizational or institutional practice setting that we can see this reflected is, for example, in holding the tension or that place of discomfort in like not allowing someone to leave. I'm talking, for example, in a Section 12 land, from a locked psych ward, or in Section 35 land from a mandatory and locked, right, rehab facility. I'm talking also about those very responses to the expression of those unacceptable feelings. We're talking about the place of harm reduction, right? That fundamental sort of personal connection-based relationship will naturally, if you are, if it is against your ethics to coerce someone to do one way or the other, make you sit with them and work with them in what fundamentally begins to look a lot like harm reduction. And this is true both in substance use world, and it's true also in mental health world. So for me, all of these tensions, and all of the sort of subsequent revealing possibilities, the good of that tension is what makes peer support roles sort of really intrinsically good at supporting people that struggle with both pieces. Because you're not asking a questionnaire mostly dedicated to substance use, or you're not solely using a questionnaire to sort of assess for mental health, what you get is the full person. And if we're talking about someone that has co-occurring substance use and mental health disorders, what we're talking about is a person who is struggling with their mental health and also struggling with coping with substances. And a person is not usually going to tell you, if they're telling you what's going on with them, with the language of those silos. And you get much, much more from talking with the person as a whole. And you can't, peer support, you should only ever approach the person as a whole.
Thank you, Celeste. So Scotty, would you like me to reread that question, or do you think you have it?
We'll find out.
All right, go for it.
I really do appreciate all that's been said. And what keeps on coming to mind to me is SAMHSA's definition of recovery, a process through which an individual improves their health and wellness, living a self-directed life and striving to reach their full potential. Like by having that, what I love about that definition, and I just put it in the chat, is that it doesn't say anything about medication. It doesn't say anything about substance use. It's all about a process of change and supporting self-determination. And like when we look at that definition, like who here today can't fit under that umbrella? Don't we all want to be well? And so having the supports has been a game changer for me. And Celeste talked about peer support. Like what I love about peer support is that I don't feel judged. And I think this is what both roles seek to do, is to create the safe space for people to talk about what's really going on. And by, sharing a little bit of our own experiences, it can help people to process their stuff. They're not being told what to do. And so that holistic approach and asking open-ended questions and really, engaging and developing, I think at the bottom line for me, it's relationship building. And because this is the first thing that has gone for me, is because of the things that have happened to me with trauma. And Celeste even kind of named it. Like, I was actually Section 12 and had that experience, and that really did a number on my ability to trust people, and also that self-doubt. So like, when we have roles, whether it's a recovery coach or a peer specialist, certified peer specialist, that can create that connection, the safety, and also to have delivered trauma-informed support. We're not going to be telling people what to do, and also we're not going to be going outside of our roles and asking invasive questions that's gonna, affect the relationship. And let's face it, trust can take a long time to build and only moments to dissipate. So I think it's in my work, I've tried to share resources with that are funded by, I guess, the Department of Public Health, funded by Department of Mental Health, and also that exist in the community. I think both recovery coaches and certified peer specialists want to help connect people with resources in the community. And like, also, which is beautiful, oftentimes, like in different segments of the world, people will be given a treatment plan. Hey, go try this, whereas I think in the peer world, we'll say, hey, you want to try something? Like, why don't we go to this recovery center together? So this is something I've done in my work, because I do recovery coaching, on the side, and also peer support on the side as well, to try to give back to people what's been freely given to me. And so by, having awareness of the different resources, like, I can make it safe to, hey, do you want to go try out this group that's at an RLC? We can go together. I can introduce you to some of the people I know there and make it safe. And then we can go to a group together, or vice versa. I worked with a transformation center for about a dozen years. And then I came over to Moore, and that's funded, primarily a lot of funding from the Department of Public Health. I, sought out those relationships. People like Val, we got our relationship back together, and we started partnering together. In fact, Val came on Tuesday night and shared her recovery story at the Moore DEI Speaker Series, and was amazing. And also, as a result of that, I learned that today is Val's 39th anniversary of, abstinence, one day at a time. So let's give it up for Valiant Val, 39 years of abstinence from substances, and just appreciate. So what we try to do, or what I try to do, is, bring people together. You share the different resources and make it so that we can have fun exploring, and and be able to learn and grow together. So that's some of the stuff that I have found vital, to be able to go places together, and then to find different pathways of recovery. I brought people from the mental health recovery side that I've met to like AA secular recovery. People, I had no idea there was a such thing as secular recovery. Also Dharma recovery, or refuge recovery, or recovery Dharma, or refuge recovery, smart recovery. I don't know. So like, this is what we try to do, is be able to go to different places, go to different events, also different peer recovery support centers, so be able to go with and then introduce people around. So I guess that's also part of Recovery Capital, the people I know, and then I can introduce people that I know, and then they can develop their support system, and then they build their recovery capital, and it keeps on growing. Like, so that mutuality is something that it's really special to me, which I think Celeste touched upon. In those peer relationships, we want to see each other as a resource. We want to learn and grow together. And we're not trying to have power over. We're trying to connect and support one another to, I guess, harness their individual recovery capital, and to be able to
Scotty,
keep
thank you
on
very
growing.
much.
So thank you, Val.
And, I would only add that, well, the three of us, we are all in dual recovery, and we have partnered to prepare for this panel for the last couple of months. And the additional support that I know I've received, because I've gotten to know Celeste better, I've gotten to know Scotty better, and they each bring their own experiences to the table, as I bring my own experiences to the table. And, the name of this panel is Engaging and Connecting. I think we landed on just one term, but I kept it for myself as Engaging and Connecting in the middle as peer specialists and recovery coaches, because we really need to engage more. We need to connect more. We need to understand what the strengths are of the recovery coaching role. We need to understand more about the strengths of the peer specialist role. They are so similar, and we gather strength from both roles. And I know that I'm going to continue to dismantle these silos a brick at a time. And I think that my friends Celeste and Scotty do the same thing. So with that, what I would like to do now is we could look at the Q&A. I think Megan's going to field that for us.
Sure. We've got several questions, so we have some time to go through that. All right, hopefully I'll get spotlighted. Okay, so let's go through some of these. Let's see. One question we can start with. Can you explain the difference between stigma and discrimination again in terms of seeking treatment?
Can I, was it directed to me, Megan?
I think it's directed to you, yeah. But if anyone else wants to contribute,
Sure.
I think that's great.
So from my perspective, stigma was a feeling that people had about me. Discrimination is withholding something from me, treating me differently. So someone could have a view of me that might be a stigma, but when something's being withheld because of who I am or how I present, that's discrimination.
Okay, that sounds great. Thank you.
Thank you.
Are there any gaps you would like to highlight in the training for certified peer specialists or recovery coaches in terms of cultural sensitivity or humility?
That's a meaty question. So I think in terms of highlighting gaps around cultural sensitivity and humility when it comes to mental health spaces in particular, all roles have massive gaps in training and capacity building. Mental health tends to be a conversation that's really dominated, is dominated by whiteness. Mental health and other institutions historically also have gone through periods of reckoning with their participation in the opposite of cultural sensitivity and humility. I think too, the ways in which we consider supports or what we consider as worthy of addressing as a source of trauma too, historically has excluded issues like systemic discrimination on the basis of race, sex, and gender identity. I think when it comes to gaps in terms of cultural sensitivity or humility in training, that is always a yes. And we can always do better.
Scott, did you want to answer too? Okay, go ahead.
The recovery coach training has acknowledged that it was a gap, and it added in the redevelopment of the curriculum portions about diversity, equity, and inclusion. Like people are being asked, like, well, what's the definition? What's the difference between equality and equity? So we're working with it, and like with any training, that there is room for improvement. You know, a friend of mine says the biggest room in my home is the room for improvement. So we try to strive to do better, but there have been adjustments made.
Great, thank you. Oh yeah, go ahead, Celeste.
Oh no, I want to mention one more thing that since we've been talking about approaching a person as a whole, someone who is struggling with their mental health, who is also struggling with substances, has a high likelihood of coming in through a very specific door of services. So there are 3 doors, right, through which a person can enter into state services. They can enter through the mental health door. So we can, for example, call a Section 12. They can enter through the substance use world. Let's call that a Section 35, or they can get arrested. We can talk about what is an ever increasing front door into mental health and substance use treatment, both if you want to separate them or as together, and that is introduction into the system via incarceration. And we can't really separate that from the heart, I think, of what this question asks, which is what are we doing within sort of both silos to be more responsive to cultural realities.
So related to this and what you just mentioned, Celeste, what ideas do you have to address the discrimination that people with mental health challenges or substance misuse face or in the medical healthcare system?
I can start with that one.
Sure.
I think it's really simple. We have to build more genuine relationships with people. That's how it has to happen. It isn't about training modules. It's about building relationships and sitting down with people and helping them to understand who we are and what our needs are. And they're not all that complicated, really. Whether I need support for my mental health or for my addiction, the support is so similar. And the main source is that of a genuine relationship with someone who cares, who accepts me for the person that I am, who will sit in discomfort as I talk and not judge. It's simple, but it takes patience and understanding and a suspension of one's beliefs. And I think there are small pockets of us that have started doing that. And we've become successful. The Dual Recovery Collaborative that I started with my partner, Ben Matthews, who works at the Women's RAP program in Taunton, we started in 2019. And it was just going to be a Central Mass area. And now it's a statewide. And we have people from Great Britain coming. We have people from New York and other states. Sometimes up to 125 people, the same size essentially as this conference, come because they all want to learn about each other so they can support people in a more equitable way. And that's the way to do it.
Thank you, Val. And Scotty.
And thank you. A great answer, Val. I would love to see more people with lived experience working everywhere services delivered, and not just like 1 or 2 people. I'm talking a good amount to be able to be effective change agents instead of having the role marginalized, because sometimes in both positions that people are being asked to do stuff out of their role. People are unaware of the different roles that recovery coaches and peer specialists do. They're able to do. And also it changes the culture of an organization. We have people with lived experience that they can develop, like Val said, relationships with. They can learn about the things that people do to get well and stay well. And it can inspire people to believe, to see people as being resilient and just seeing up close and personal and carrying the message that people can recover and that recovery is real. Thank you.
Thank you, Scotty. Another question was, where can you find listings of local community resources, support groups, and clubhouses? And looks like we just put in a list.
Yeah, Heather loaded up the resources that I sent to her. And what we have in the resource list, we have a list of the Massachusetts clubhouses. Many of the Massachusetts clubhouses also have Dual Recovery Anonymous meetings. And the Massachusetts Clubhouse Coalition has a contract with the Mass Behavioral Health Partnership to develop dual recovery leadership programs. And all of the virtual meetings are listed there. There's about 70 meetings a week that are free and available for people. We also have the Massachusetts Organization for Addiction Recovery is there when they talk about recovery coaches, the peer support centers, the two larger ones, the Kiva Center and Wildflower, their websites are there. The Mass Substance Use Helpline is there. How to apply for DMH services, that application is there. The BSAS recovery centers, how many, Scotty? About 40 now? About 40. And then I'm not sure how many of the recovery learning communities there are. It isn't equitable, I know that, but there's probably about maybe 15. I think I'm kind of close.
Thank you. That's an excellent list. So thanks for providing that.
I have one
another-
more thing to say, Megan.
Sure,
I
go
know
ahead.
we're coming up on the thing. So, what happened in my recovery when I pulled together the mental health and the substance and found the tools that I have found in dual recovery is that I went from a place of abstinence, meaning I wasn't drinking and I wasn't drugging, to a place of real wellness. That's the difference. When you can get support for both, you can go from abstinence to wellness, to having a good job, to making presentations in front of people, to getting married, to having grandchildren. There's abstinence isn't good enough. It isn't, it's a starting point. But I strive for wellness, and I hope everybody here will support people to find wellness as well.
Thanks, Val. Then we have, Scotty, do you want to go?
I second the same thing by getting support for mental health recovery, trauma recovery, and addiction recovery. I've been able to put together almost 17 years abstinence, and I have a wife, home, children, and been able to have a full-time job. And I give it credit by having a wellness plan and having skill supports and resources to be well one moment at a time. So thank you.
Thank you. Okay, we have like 2 minutes. So if you have a quick answer to this one, we could go through it. What, aside from more money, do you feel is most needed in our RLCs and RCCs?
I mean,
Collaboration. Come play with each other.
That's great. Celeste, do you want to add?
I did, and I second, what Val said, but I guess I'm still thinking about the question before in terms of what can we is there anything actionable that we can do to address the discrimination that people with mental health diagnoses or substance use on their record, so somewhere visible, or if as they're presenting face in healthcare settings, and I guess I just want to acknowledge that that is a very complicated question, especially in an incredibly stressed system. But what it made me think of that maybe doesn't sound actionable, but is when you are in a position where you're interacting with someone who, is struggling in either one of these ways, especially in a professional capacity. When you look at them, where do you see them in 5 years? Where do you see them in 10 years? And be really honest about what that says about how you see the person and how possible you think recovery and what that looks like is for that person. I think that actually might in many ways be actionable too within healthcare systems of a physical
All right,
healthcare variety.
we gotta hold you there. We're right at our time. Look at that, we did it. Thank you all so much. It's been a pleasure. We'll turn our cameras off now and take a break. Thank you very much.
And I just want to thank you so much for that incredibly powerful panel discussion. I know it's touched a lot of people, so thank you so much. All right, so we have hit our break. We have a 10-minute break. So get some coffee, come back at 2:35 and we'll continue. Thanks. Great. Okay, it's 2:35. Hopefully everyone is back. So I'll introduce the next speaker. It is my pleasure to introduce Dr. Laura Kelly for the next presentation. Dr. Laura Kelly is an assistant professor of psychiatry and faculty member of iSpark at UMass Chan Medical School. She is a clinical psychologist, having completed her doctoral training at Suffolk University's clinical psychology program in Boston, Massachusetts, and her postdoctoral research at the University of Connecticut School of Medicine. Her research broadly focuses on suicide prevention within transition-age youth with alcohol and other drug use disorders, particularly using technology-based interventions. She was awarded a K99 ROO Pathway to Independence Award, which provided mentorship and advanced training to support her research on developing and evaluating a technology intervention for emerging adults with alcohol use problems and suicidal thoughts for delivery in the emergency department. We are thrilled to hear about her important work on identifying who may be at highest risk of co-occurring substance use disorders and suicide. Thank you, Dr. Kelly, for presenting today. So I am going to hand it over to you.
Thanks so much, Megan. It's really my pleasure to present to you all today. I'm going to be talking about which groups have the highest rates of co-occurring substance use disorders and suicide risk. And all of this data are from a national representative survey in the United States. I don't have any conflicts of interest to note. My opinions don't represent those of the National Institute of Health or the Massachusetts Department of Health, Mental Health, but these are the different grants that provide funding for my research. I also conducted these analyses when I was a postdoctoral fellow because I have a strong interest in co-occurring suicidal thoughts and substance use disorders. I also do some consulting that's unrelated to this presentation. So our learning objectives today are to identify the age group at highest risk of co-occurring suicidality and substance use disorders, identify other demographic groups based on gender, sexuality, and race and ethnicity who may be at higher risk of suicidality and substance use disorders, and then to understand intersectional risk factors. So when someone has more than one minoritized identity. So where is this data from? Luckily, I did not have to collect any of this data. This data is freely available to anyone who wants to analyze this national survey. It's called the National Survey on Drug Use and Health, and it's administered by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. So as folks had noted before, we tend to use person-centered language to help destigmatize persons who use drugs or alcohol. And it's actually perfectly acceptable for somebody in a smart recovery group or mutual aid group to say something at the beginning of a meeting like, I'm an alcoholic or I'm an addict. And using those self-statements is not associated with more stigma about oneself or negative perceptions. It actually takes an act of Congress to change the title of these federal agencies. So I'm going to drop some links in the chat if you're interested in changing your language around substance use, but that's why this term abuse is used here. I also will not be using any visuals or images of people using drugs or alcohol or of paraphernalia, like tools that people use to use drugs. And that's because of some really great research that's been out on images to destigmatize substance use disorder. So I'll be putting those links in the chat later. So who is included in the National Survey of Drug Use and Health? So this is among civilians who are age 12 and older, using face-to-face and computer-assisted household interviews. And in 2020, they added web-based interviews. But this is people who are in non-institutionalized group quarters. So houses, apartments, but also homeless shelters, boarding houses or recovery houses, college dorms, work camps. It does not include, though, people who are in institutional group quarters. So people who are unhoused but not in shelters, active military, persons in jail or prisons, nursing homes, psychiatric hospitals, or long-term care hospitals. Also, because I did not collect this data, I have the information based on what was collected. So the item that asks about gender is, what is your gender? But the options are male and female, which would usually be used to assess sex assigned at birth. So it's one limitation. The racial and ethnic group information, it also includes anyone who is Hispanic and identifies as any other racial group. That's because of some research that suggests that people's racial and ethnic identity, if they're Hispanic, that's their primary identity. But if somebody is, say, Afro-Latina, they would be put into the Hispanic category. So these are just some things when you're working with secondary data analyses. All right, so the conclusions I'm going to be talking about are from 4 secondary analyses from the NSDA data. So I do not work at SAMHSA, but SAMHSA does some analyses based on demographic groups. So they look at if men or women have higher rates of substance use disorders, but they don't look at co-occurring suicidal thoughts, plans, or attempts and substance use disorders. They also don't tend to combine groups. So they wouldn't be doing analyses to look at if somebody with both a minoritized racial identity and a minoritized sexual identity have higher rates of substance use disorder. Also, for these analyses, we control for some other variables, meaning we put those other variables in our models, and that kind of makes a more accurate or clearer picture of the contributions of things like gender, age, race, and sexual identity. So they're just some strengths of these analyses. So these are 4 papers that cover a range of substances and suicidality. By suicidality, I mean suicidal thoughts, plans, and attempts. They're all first author papers of mine in peer-reviewed journals. So it's the Journal of Affective Disorder, Drug and Alcohol Dependence, and Addictive Disorders. Addictive Behaviors. 2 are brief reports. Means they're shorter papers because some of the groups were a little bit small, making it more difficult to have accurate conclusions. So for example, folks who are Black or African American and lesbian or gay or bisexual and reporting suicide attempts and substance use disorders, those groups get quite small. And so we focus on suicidal thoughts and substance use disorders. So just some things to note when you see some of the differences. We also looked at 2015 to 2018 data or 2015 to 2019 data. In 2020, something happened. I don't know if you all remember, but COVID made it very difficult for SAMHSA to collect data in the same way that they had previously. So they added web-based interviews, but that 2020 data is a little bit unreliable in terms of the substance use disorder estimate, so can't be combined with the previous data. And then in 2015, they added sexual orientation as a variable, so I didn't have previous data from there. Right, so first we examine rates of alcohol use problems and 4 suicide risk variables. So there's 2 ways people get questions about suicidality in the NSDUH, the National Survey of Drug Use and Health. So if someone reports any depressive symptoms, meaning they say yes to, they've had a period of 2 weeks or more of depressed mood or loss of interest, then they get 4 questions. So the period where their mood was worse, they have wishes for death, suicidal thoughts, suicide plans, or suicide attempts. And then everyone in the United States who's an adult gets questions about in the past year if they've had suicidal thoughts, plans, or attempts. So these analyses specifically are among all people who had any level of depressive symptoms in the past year. Now I'm going to orient us to this slide a little bit. We did 2 kind of sets of comparisons. First, we had 4 groups. So people with neither suicidality nor alcohol use disorder, people with suicidality only, but not alcohol use disorder, people with alcohol use disorder only, but not suicidality, and then people with co-occurring suicidality and alcohol use disorder. So we're most interested in co-occurring suicidality and alcohol use disorder. I'm going to show you the numbers for the first comparisons that we did. So with wishes for death and alcohol use disorder. And then I'll tell you about the results of the other things that we looked at. So suicidal thoughts, plans, and attempts. Then the other comparisons we did were by age and gender. So we compared 18 to 25-year-olds to all older age groups, and then men compared to women. So what we found was that 18 to 25-year-olds compared to all groups of older adults, ages 35 and older, had greater odds of co-occurring wishes for death and alcohol use disorder, thoughts of suicide and alcohol use disorder, and suicide plans and alcohol use disorder. But age differences in suicide attempts and alcohol use disorder were not significant. And then for gender, men had higher odds of suicidality and alcohol use disorder, all 4 of the ways we looked at suicidality and alcohol use disorder compared to women. We also looked at binge drinking and suicidality. So if binge drinking is maybe a lower level of alcohol use problems than alcohol use disorder. So we found kind of different patterns. So emerging adults had higher odds of wishes for death and binge drinking compared to all older age groups, as well as suicidal thoughts and binge drinking, and suicide plans and binge drinking, as well as suicide attempts and binge drinking. So suicide attempts and alcohol use disorder were not significant by age, but were for binge drinking. And then it was kind of opposite for men. So men had a higher odds than women of thoughts of suicide and binge drinking. So putting this all together, so among people with any level of depressive symptoms, emerging adults and men had the highest odds of suicidal thoughts and alcohol use disorder. And emerging adults and men had the highest odds of suicidal thoughts and binge drinking. So in no analyses were older adult groups or women more likely to have suicidal thoughts or alcohol compared to men. For suicide attempts, men had higher odds of alcohol use disorder and suicide attempts than women, and emerging adults had higher odds of suicide attempts and binge drinking than all older age groups. So there are maybe fewer differences when it comes to suicide attempts and alcohol use problems. All right, so we'll keep this in mind. So men and emerging adults had the highest odds of suicidality and alcohol use problems. So next we wanted to look at cannabis use disorder. So cannabis is the second most commonly used substance in the United States. It's going more likely to be used with increased legalization, and it's thought of as more maybe distantly related to suicidality. There's some chemical reasons why alcohol is associated with suicidality. It lowers inhibitions and can make people more likely to act on suicidal thoughts because it's a depressant. So cannabis might operate a little bit differently. So we were wondering, are men and emerging adults still more likely to have co-occurring cannabis use disorder and suicidality? We also wanted to look at racial, ethnic identity, and sexual identity. So we found similar patterns that young adults or emerging adults compared to all older age groups had higher odds of thoughts of suicide and cannabis use disorder, and suicide attempts and cannabis use disorder. And then men had higher odds of thoughts of suicide and cannabis use disorder compared to women, but not suicide attempts and cannabis use disorder. So for racial and ethnic groups and sexual orientation groups, we found that Black and African American, then Native American and Alaska Native, and Native Hawaiian and Pacific Islanders all had higher odds of thoughts of suicide and cannabis use disorder. And then the numbers aren't shown here, but Black and Hispanic adults also had higher odds of suicide attempts and cannabis use disorder. Then in terms of sexual orientation, gay and lesbian and bisexual adults had higher odds of thoughts of suicide and cannabis use disorder, but not suicide attempts and cannabis use disorder. So again, there are fewer differences in terms of suicide attempts and cannabis use disorder. So taking this all together, who has the highest rates of suicidal thoughts and cannabis use disorder? So it's emerging adults, 18 to 25, compared to all older age groups, men compared to women, bisexual, gay, and lesbian adults compared to heterosexual adults, Black and African American compared to white non-Hispanic adults, and Native American, Alaska Native, and Pacific Islanders compared to white non-Hispanic adults. And for suicide attempts and cannabis use disorder, there are fewer group differences, but still the same patterns or similar patterns. So emerging adults compared to older adults, and Black and African American and Hispanic and Latinx adults compared to white non-Hispanic adults. So the next two papers examine intersectionality. So people with both a minoritized racial identity and sexual identity. I just want to note here that the National Survey of Drug Use and Health only assesses lesbian, gay, or bisexual or heterosexual identities. So these are groups that you'll see compared to heterosexual adults. So here, we also examine differences based on gender. So we did the same analyses for men and for women, because there's some evidence that if someone is a woman and Black and lesbian, so they have 3 minoritized identities, that they're at even greater risk of substance use disorders and suicidal thoughts. But generally the patterns that we found were the same for men and women, and I'll note just the one difference that we found. So first here that you'll see are that Black or Hispanic, gay and bisexual men had higher odds of co-occurring substance use disorder and suicidal thoughts compared to white heterosexual men. And then Black, Hispanic, or white, gay and bisexual men had higher odds of substance use disorder and suicidal thoughts than their same race peers. But if someone is Black or Hispanic and heterosexual, they had lower odds of substance use disorder and suicidal thoughts than white heterosexual men. So that means that there's a protective effect of being Black or Hispanic if somebody is heterosexual. And then Black and Hispanic gay and bisexual men were not significantly different from white gay and bisexual men. So there is a protective effect of being Black or Hispanic only if you are heterosexual. We also didn't necessarily see like a compounded or additive effect of being Black and Hispanic and gay or bisexual. So Black and Hispanic and white gay and bisexual men were similarly high. And that might be because if someone is Black or Hispanic, they don't have the protective effect of like their racial group if they are also gay or bisexual. So these patterns were similar for women. So Black or Hispanic, lesbian, gay, or bisexual women had higher odds of substance use disorder and suicidal thoughts than white heterosexual women. And then Black, Hispanic, and white, lesbian, gay, bisexual women had higher odds of substance use disorder and suicidal thoughts than their same race peers. And Black or Hispanic heterosexual women had lower odds of substance use disorder and suicidal thoughts than white heterosexual women. So again, there's a protective effect of being Black or Hispanic, but only if somebody is heterosexual. And then Black, lesbian, gay, bisexual women had lower odds of substance use disorder and suicidal thoughts than white, lesbian, gay, bisexual women. And Hispanic and white, lesbian, gay, bisexual women weren't significantly different from each other. So that means that Hispanic and white, lesbian, gay, bisexual women were similarly high, followed by Black, lesbian, gay, bisexual women, followed by white heterosexual women, and then Black or Hispanic heterosexual women. So there wasn't necessarily a compounded or additive effect of having both a sexual and racial minoritized identity. There's just not a protective effect of somebody's racial group if they are also lesbian, gay, or bisexual. So I'll say that again. So among all adults, the groups who have the highest rates of suicidal ideation and substance use disorder are folks who are Black and Hispanic and lesbian, gay, or bisexual, and then white, lesbian, gay, or bisexual adults. And so Black and Hispanic, lesbian, gay, bisexual adults had higher odds of co-occurring suicidal thoughts and substance use disorder compared to their same race heterosexual peers and compared to their white heterosexual peers. And then Black and Hispanic heterosexual adults actually have lower rates of suicidal thoughts and substance use disorder compared to white heterosexual peers. Next, we wanted to look at Native American and Alaska Native groups and intersectionality because these group sizes were too small to run in the models with the previous study. So these models only examine co-occurring suicidal thoughts and alcohol use, binge drinking, and alcohol use disorder between white and Native American and Alaska Native groups. So here what we're showing are very similar sets of analyses with alcohol use and suicidal thoughts. And what this is showing here are that Native heterosexual groups have lower odds of co-occurring alcohol use and suicidal thoughts than white heterosexual adults. But Native, lesbian, gay, bisexual groups have higher odds of co-occurring suicidal thoughts and alcohol use compared to both white heterosexual and Native heterosexual groups. And then Native and white lesbian, gay, bisexual groups are not significantly different from each other. So Native and white lesbian, gay, bisexual groups are similarly high or not significantly different from each other in high, followed by white heterosexual adults, and then Native heterosexual adults have the lowest odds. So again, there's that protective effect of being Native American or Alaska Native, but only if you are also heterosexual. And then here, these patterns are similar, or there's one difference when we're looking at binge drinking and suicidal thoughts and alcohol use disorder and suicidal thoughts. So these just don't show a protective effect for Native American heterosexual adults. So here, Native American heterosexual adults are not significantly different from white heterosexual adults, but Native lesbian, gay, bisexual groups are similarly higher compared to white heterosexual and compared to Native heterosexual groups. So what this says are, if you are Native and lesbian, gay, or bisexual, or white lesbian, gay, or bisexual, you're similarly higher compared to both Native and white heterosexual adults. And then these same patterns were there for alcohol use disorder and suicidal thoughts. So these patterns were there for binge drinking and suicidal thoughts, and alcohol use disorder and suicidal thoughts. Okay, so for who has the highest rates of suicidal thoughts and alcohol use, and of binge drinking and of alcohol use disorder, it's folks who are Native American and lesbian, gay, or bisexual, or white and lesbian, gay, or bisexual. So being Native American is protective, but only if somebody is also heterosexual. And kind of the flip side, in no analyses were folks who were heterosexual and either of a single minoritized identity or a doubly minoritized identity. So essentially, people who are white and heterosexual didn't have higher odds in any of these analyses that we ran. So what does all of this mean? It means that we should direct suicide and addiction prevention and intervention efforts to emerging adults, so 18 to 25-year-olds, and to men, and to people with minoritized sexual identities and racial and ethnic identities. So especially to people who are Black, Indigenous, people of color, and Hispanic, and lesbian, gay, or bisexual. So there's something about the intersectional experience of being a sexual minority within the Black and Hispanic and Native communities. And I'll talk about in the next slide what that doesn't mean. So what we could do is direct-to-consumer marketing strategies for prevention and intervention for suicide and substance use disorders. So that means the same way that we have commercials or ads for medications, we would have those commercials and ads directed to people who may be at higher risk of co-occurring suicidality and substance use. This could also look like making our brochures, social media outreach, websites, referrals specifically to these groups, and making sure our photos in any of those areas really reflect these groups. And these should not be photos of people using or clutching their head or looking like they're in pain, or people that are in this like halo of light. Sometimes we see that on websites for mental health or substance use treatment, because that halo, according to persons with lived experience, is perceived as kind of unrealistic. And instead, there's been some excellent research that the publication is here that shows what photos of treatment could look like, that it should emphasize connection. And
Laura, sorry to break in here. We have to wrap it up. We have to move on. So could you wrap it up real quick?
Yes.
Thanks.
So we would just have connection and overcoming obstacles and progress or journeys. The only thing I just want to mention that this doesn't mean that people are susceptible based on a genetic or biological risk for substance use and mental health difficulties. This risk is related to prejudice and discrimination and colonization. And then I feel like I mentioned throughout the presentation some limitations of the data collected, so groups that this doesn't necessarily apply to. And then just to reiterate, it's emerging adults, men, persons with sexual minoritized identities or racial identities, and then folks with intersectional racial and sexual identities are at greatest risk for suicidality and substance use disorders. And then I just have lots of social media. Thank you.
Really, really appreciate that. We won't have time for Q&A, so I apologize for that too. But I was wondering if you could go in and answer the questions in the Q&A and type some answers in there, because we have some really good questions in there. So thank you again. It was a pleasure to hear this presentation with wonderful information. And I will turn it over to Corey.
Thanks so much, Laura. That was wonderful. And thank you, Megan. So now it's my pleasure to introduce another one of my wonderful colleagues, Dr. Randy Schuster, Director of School-Based Research and Program Development for the MGH Center of Addiction Medicine and Associate Professor at Harvard Medical School. Dr. Schuster's research has focused on defining the impact of early substance use on cognition and mood, identifying the factors that increase risk for problematic substance use among adolescents with co-occurring psychiatric illness. And from this foundation, she has developed and implemented programs aimed at helping schools detect and intervene early on substance use. Dr. Schuster's work has had an outstanding local impact. She has developed extensive relationships with public, middle, and high schools in Massachusetts, surveyed over 75,000 students about their substance use, mental health conditions, and access to mental health care. She has spearheaded a large pragmatic clinical effectiveness trial of a novel school-based substance use diversion curriculum called iDecide. Check out our website. That is currently being tested in nearly 400 schools across the Commonwealth. Her work seeks to inform policy that will reduce rates of early substance use, equip schools with a continuum of substance use support services from prevention to targeted intervention, and improve access to school-based and culturally sensitive substance use programs, particularly in underserved communities. I'm so delighted that she is here today to speak with us about this work. Thank you, Randy.
Okay, I think I'm good to go. Sorry, everyone. Well, thank you, Corey, for that very, very generous introduction, and thank you for inviting me to be here today. I am really pleased to be in community with everyone here, and just really grateful to be a part of this amazing panel of speakers and to be speaking with you all today. So my presentation today isn't very data heavy. I am going to be talking to you more about an idea, a paradigm shift, an opportunity to really work with schools to support our kids, primarily through a lens of prevention, targeted prevention. My goal for today is largely threefold. So I will share with you, I guess we'll do some level setting, talk a little bit, make sure we're all on the same page in terms of the state of the science around our youth's mental health and the crisis that I'm sure everyone on this call is very much aware of. Number two, we'll try to convince you all in just a few slides around the opportunity that we have ahead of us to partner with schools to support kids from a more proactive, more preventative, more equitable stance. And number three, I want to just showcase, highlight some of the work that we are doing out of the Center for Addiction Medicine, which is my home base at MGH, to work with schools, primarily focused around youth substance use, but hopefully use that as an opportunity to think together around other ways that we can be working with schools. And so before I dive in, I just want to quickly acknowledge the primary funders of the work that I will be showcasing to you today. So we have a longstanding relationship with the Department of Public Health in Massachusetts, specifically the Office of Youth and Young Adult Services. Always have a hard time getting that out. In the Bureau of Substance Addiction Services. They have funded our I Decide program and our joint funders of our program focused on improving universal screening for substance use, which I'll be showing you some of that work in a little bit, as well as PCORI, which is funding our work around SBIRT. Now, so first, let's do some level setting, and you know, I won't spend too much time here because I'm sure this is, sorry, let me minimize my screen here. Okay. Here we go. This is going to be of no surprise to everyone on this call, but we are still in the midst of a youth mental health crisis, and this really was unleashed with the COVID pandemic, which ushered in a new set of challenges for youth in the United States, leading to a mental health crisis as declared by the United States Surgeon General. From 2009 to 2019, the proportion of high school students reporting persistent feelings of sadness or hopelessness increased by 40%. The share seriously considering attempting suicide increased by 36%. And the proportion creating a suicide plan increased by 44%. And these rising rates in youth distress are likely driven by a variety of factors that span multiple levels of influence, ranging from at the level of the individual to society. So not only, and this has been raised by a lot of folks that I work with, is that and parents and schools, this generation is more willing to openly discuss mental health concerns than prior generations, but that doesn't fully explain the crisis that we are in right now. Researchers also point to the growing use of digital media, social media, increasing academic pressure, limited access to mental health care, health risk behaviors such as alcohol and other substance use, and broader stressors, including financial crises, rising income inequality, racism, gun violence, climate change. Vis-a-vis the COVID-19 pandemic, we know that, for example, about 1 in 3 U.S. high school students had a parent or caregiver who lost their job, really setting the stage for increased stressors that might contribute to expression of a variety of mental health concerns in young people. Now, findings of increasing levels of distress and disconnection are especially stark among some groups of students, as was highlighted in the prior speaker's presentation. Female students, for example, experience more violence, more mental health challenges, higher incidence of suicidal thoughts and behaviors, often higher levels of substance use or presentation for substance use concerns. So, for example, findings show that female students are nearly twice as likely to experience persistent feelings of sadness or hopelessness, nearly twice as likely to attempt suicide during the past year compared to male peers, and nearly 60% of females at the time of that survey report feeling sad or hopelessness, with where about 1 in 10 endorsing a past year suicide attempt. And as we've seen in prior data, we see that that sexual and gender minoritized students continue to experience more violence, more mental health distress than heterosexual peers. So in 2021, more than 1 in 10 LGBTQIA+ students reported not going to school because of safety concerns, About 25% reported experiencing sexual violence. About 25% reported being bullied in school in the past year. So what I have up on the screen here are some data from some of our surveys that we've conducted out of the Center for Addiction Medicine, where we show that, these data have been spearheaded by my colleague Gladys Pachis, showing an interaction between this greater incidence of mental health distress is also not even shared uniformly within the LGBTQIA plus population. We see that young people who identify as both sexually diverse and gender diverse have an even higher incidence of depressive symptoms, anxiety symptoms, suicidal thoughts and behaviors, suicide attempts, as well as non-suicidal self-injury. We also have data ongoing in our center. This is being spearheaded by an amazing postdoc, Nestor Noyola, who is showing, and apologies, there's a lot going on the screen here, but I'll really distill this down for you, which is showing, and I think this is a really critical point in thinking about disparities in prevalence of mental health distress, particularly among minoritized youth, that we're not making the inference that these disparities are due to something inherent to this population, but rather trying to triangulate the specific exposures that these individuals are more likely to experience, which are modifiable, preventable, and really trying to understand the pathways by which we see greater expression of mental health symptoms. So what Dr. Noyola finds in some of these ongoing analyses is that sexual and gender diverse youth are more likely to experience gender-based discrimination, sex-based discrimination, which results in increased emotion reactivity, which then drives the increased incidence and prevalence of depressive symptoms, anxiety symptoms, as well as self-injurious thoughts and behaviors. So to me, this really drives the point home that we, as we've seen from in a very, very robust scientific literature, a greater incidence of and greater prevalence of mental health symptoms in minoritized youth, but also really trying to get square on what are those exposures that these youth are likely to experience, so that we can be thinking about prevention-based programs as well as intervention-based programs that target those exposures, right? Not are targeting the individual, and not suggesting that there is anything inherent there or intrinsic about their identity, but really trying to intervene on behalf of those putative risk factors. So how do we get to schools here? So, we are in amidst this persistent youth mental health crisis, and there has been a lot of attention to increasing the number of beds and trying to support kids from the stance of among those who have already expressed significant distress. But the vantage point that I come from is that we are really not going to make significant headway if we don't turn the spigot off. Trying to think about how we can intervene more upstream in a way that is targeted, informed, and trying to prevent progression of mental health symptoms. And what I want to argue to you, and hopefully we can discuss a bit in the Q&A, and happy to continue any conversations offline, is that schools are a really integral part of this effort to turn the spigot off, so to speak. Schools play a very critical role in shaping mental, physical, and social growth. And I would argue, and have seen the promise of this firsthand in my work, that schools are really best poised to represent the prevention arm of our youth mental health system. Now, I want to take a few slides to, at a very, very high level, try to convince you of the unique space that schools are able to hold. vis-a-vis prevention-based work. So the first is that schools are a critical access point to improve equity. The truth of the matter is that youth as a whole are not well connected with care in the community. No-show rates for initial intake are high, with 1 in 2 young people not showing for their first appointment. And even once kids do show up, are brought to care for their initial intake, attrition is also high. Schools can really help increase student access to health services, including mental and behavioral health services, by providing on-site school services or by referring students to youth-friendly sources of care in the community. And schools can also support access to services by assessing the needs of students, as well as the availability of off-site services. Establishing relationships, one of the things that has become very, very clear to me in our work is that, this is one of those very obvious statements, but is that access to services is very community dependent. Even here in Massachusetts, where there are a wealth of opportunities and services available, it varies dramatically community by community. And who knows those communities better than the schools themselves? The second piece around really the unique opportunity that we have when working with schools is that schools have the opportunity to help enhance youth connectedness and reduce stigma. So school environments that are safe and support young people help kids feel connected to their peers and adults in schools. And this sense of connectedness has been shown to have long-standing, long-lasting protective impacts on health and well-being. Findings from a study in pediatrics, I believe published in 2019, find that youth who reported feeling connected during middle and high school had fewer problems with substance use, mental health, suicidal thoughts and behaviors, as well as risky sexual behaviors as adults. Multiple different strategies that we can talk about that schools can take to improve connectedness, some of which being making sure teachers have the training they need, providing opportunities for positive youth development, ensuring that schools are safe, particularly for those most susceptible to experience bullying and discrimination, including those from various minoritized sociocultural backgrounds. The third piece, the third of 4 that I'm going to highlight in terms of the unique space that schools can hold, or the unique opportunity in partnering with schools to support youth mental health, is the potential to leverage the proclivity for social contagion for good. So as you all know, kids talk with each other. Kids are responsive to peer influences, and particularly during the adolescent developmental window, are particularly responsive to the influence of their peers. And some of the work that I've been really moved by in kind of serving as the foundation for much of my youth school-based work has found the contagion effect of preventative-based programs. So not only showing the impact of targeted prevention programs on the kids that were targeted by that intervention itself, but on the ring just right outside of those kids, right? So there have been a number of studies published in recent years showing that peers of kids who were receiving interventions report increased in knowledge, increases in perceptions of harm around substance use, decreases in various different mental health symptomatology, really supporting the fact that intervening on one in schools may actually mean intervening on many, right? Both in terms of youth peer-to-peer transmission of information shared during various different interventions, but also in terms of overall kind of restorative school culture. that implementing programs at schools around that are focused on youth mental health promotion, prevention, substance use education, takes an important step in creating space for kids and setting the tone that this is a place that is okay to not be okay, right? And the last piece that I want to mention here in terms of the opportunity with schools is that schools are sit in this place where they have dense contact as well as historical relationships, which allow for intensive monitoring during very sensitive developmental windows when progression of mental health symptoms can occur quickly, right? And so it is really important to, progression of symptoms happens very quickly during adolescence. And so who better to be able to monitor on a day-to-day, week-to-week, month-to-month basis than schools. These are the people, aside from those who are at home, caregivers and loved ones at home, who are seeing students over, repeatedly over this period of time. So when we talk about school-based supports, they tend to be, and I will say that this schema that I have presented here is actually undergoing a current evolution. So this is this triangle is moving into a diamond, but in its current state, school-based behavioral health programs as well as academic supports tend to be organized along this this pyramid, this multi-tiered system of support, which essentially and very simply shows that supports are graduated in response to progressive indication of need. Okay, so at the base of the pyramid, tier 1, this is school-wide. This is universal. So with regard to mental health supports, think 9th grade health ed class, sex education, right? It goes to everyone, independent of any sort of indicated risk factor or manifestation of symptomatology, right? It is universal prevention. Tier 2 is targeted. So you might hear this called indicated prevention, targeted prevention, tier 2 intervention, all of these terms you might hear. And so essentially this is the space where interventions, typically lower touch interventions, shorter, briefer interventions, tend to be delivered to students with the goal of preventing progression of symptoms and are delivered to students based off of identified need, early expression of symptoms, or on behalf of some sort of risk factors. Lastly, tier 3 tends to be individual and intensive. So for students who are demonstrating clinical acuity or have expressed, have meet criteria for a mental health diagnosis. I will say in my work, we tend to focus on this tier 2 space, right? So targeted prevention. This is what we've heard from schools as this black box. Schools tend to be pretty well supported in that tier 1 space. Tier 3 tends to be, is difficult to ignore, right? If a student is in crisis, we know we need to rally supports around them. Tier 2 is challenging, right? Because it requires us to identify need and to do so early, right? And intervene on behalf of those risk factors to try to prevent progression. So what I'm going to do is just show you in our remaining time together at a very high level, and again, happy to discuss in greater detail offline if there's any interest in any one of these programs in particular, some of the work that we are doing in this tier 2 space. So the first is around universal screening. As I mentioned in one of the slides where I was showing you reasons why schools are uniquely positioned to support the targeted prevention of mental health symptoms in youth, is that we need to be able to identify symptoms early. So there's been a lot of interest in universal screening. In my group, we do a statewide school survey. It's called the SURF survey, Substance Use and Risk Factor Survey. We've been doing this since 2016 in some form or another. In 2022, last year, we surveyed about 28,000 students across the Commonwealth, about 26,000 students this past fall. And the goal of this survey is to be able to document prevalence estimates and to be able to look at risk factors for progression over time, as well as to give schools back very tailored data about how kids in their district are faring.
Randy, can I ask you to do a 2-minute wrap up so we have time maybe for one question, or we may not have time? Thank you.
No worries, no worries. So I'll show you just a few things real quickly here. So these are some data that my colleague Brendan Turbo-Clemens published in JAMA Pediatrics at the beginning of this year. These came from Massachusetts high school students just last year. So these are our kids, and very recently, our kids recently. And what we show here is that substance use has a dose-dependent relationship with various psychiatric symptoms. And just for purposes of time, I want to move forward and show you, the surveys that we do tend to be anonymized, but one of the things we've been exploring with schools to help support early more targeted prevention is giving kids the option to break confidentiality through these anonymized surveys. So at the end of the surveys, we're now giving kids the option to say, I've had the opportunity to reflect on my mood and my behavioral health. I would like you to connect me, to do a warm handoff or a referral to someone at school to get support. And what we found is that there was a striking number of kids who said yes. Right? If they were given the option to get help, they said yes. About 1 in 5 kids said yes. Importantly, what we see that is among the kids who opted in for a warm handoff, they were more likely to experience symptoms of depression and anxiety, more likely to have psychotic-like symptoms, more likely to have higher levels of emotion reactivity, more likely to report frequent alcohol use, more likely to have attempted suicide in the last year. And importantly, about 40% of those kids who said, yes, help connect me to care, 40% of them reported not talking to anyone in the past year about their mental health symptoms, really underscoring the fact, and this was so simple. This was such a simple strategy, and many of the schools in the Commonwealth are required to do biannual anonymized surveys for substance use. And just a very simple way of helping get kids connected to care.
Randy, can I stop you there? And I just want to ask one question that's kind of relevant, and then I think we have to wrap up. But someone in the chat was a bit concerned that a lot is being asked of teachers. Can you just speak to who is delivering the intervention and whether this is added burden onto teachers and how you've handled that?
It's a great point. And so, and actually, some of the work that we are doing with Mass DPH as well as with PCORI is around this idea. So there have been a lot of unfunded mandates that have been placed on schools, a lot of do more without any additional resources to do it. So one of the programs that we've been thinking about is around SBIRT, which is a state mandate in Massachusetts. I believe we're the only state to require it by law, which requires schools and largely school nurses to do annual screenings in one middle school, one high school grade for substance use. But for most schools, this came without any additional funding to do that. What we've been exploring is the opportunity of mobilizing a novel and expanded workforce and partnering with people outside of the school to help come into the school to support some of these behavioral health initiatives. And what we're seeing in this early work, so this was our first year of doing an augmented SBIRT screening, where we had what we're calling youth wellness coaches. These are near peers with lived or living behavioral health experience to support universal screening in schools. We found that substance use disclosure was twofold higher in kids who were screened with a youth wellness coach. And 95% of students who did SBIRT screening with a coach reported that they answered honestly, compared to only about half who were screened by school staff. So I'll wrap by showing just this here, which gets to exactly to your point, Corey, which is that while schools are uniquely positioned to leverage prevention approaches, such as universal screening, to promote early identification and treatment, really which outstrip models that rely solely on crisis management or reactive approaches to behavioral health challenges, there are challenges ahead that need to be navigated with care to ensure implementation is sustainable and equitable. Funding is going to be a major facilitator here. We cannot do this in a robust and equitable way without actually supporting our schools, putting our money where our mouth is, and making sure that schools are involved in the conversations around both what these programs are and how they are going to be implemented. Schools are very distinct from each other, and they're very distinct from a traditional care setting, and we need to make sure that those stakeholders are involved in how we define what our next steps are.
Wonderful work. Thank you so much.
Thank you so much for having me.
Okay. I have the pleasure of introducing our next speakers. It's my pleasure to introduce Doctors Anderson and Wilkins for the next presentation, Signs of Safety, a Deaf Accessible Therapy Toolkit for Co-occurring Trauma and Addiction. Dr. Melissa Anderson is an Associate Professor of Psychiatry at UMass Chan Medical School. She is a Gallaudet University trained psychologist and clinical researcher who strives to provide accessible behavioral health care to members of the U.S. deaf community. She founded the Deaf Yes Center for Deaf Empowerment and Recovery at UMass Chan Medical School in 2014, where she and her team provide outpatient therapy and conduct groundbreaking research on deaf mental health. Most recently, Dr. Anderson and her team received a 5-year, $3.6 million award from the National Institute on Alcohol Abuse and Alcoholism to launch the first nationwide therapy clinical trial for deaf people. Dr. Anderson is one of those rare psychologists who truly embodies a balance between clinical work and academic research that is informed by community engagement and health equity. Dr. Alexander Wilkins is an assistant professor at UMass Chan Medical School, where he is also the co-director of the Deaf Yes Center for Deaf Empowerment and Recovery at UMass Chan. He is a recipient of an important K-23 Career Development Award from NIAAA to develop and validate a deaf-accessible motivational enhancement treatment for alcohol use disorder. His program of research focuses on a community-engaged approach to developing resources for mental health and behavioral health care for deaf and hard of hearing individuals. He also provides outpatient mental health services for deaf and hard of hearing individuals as a clinical psychologist. Dr. Wilkins is a true scientist practitioner dedicated to improving behavioral health services for the deaf community with his research and clinical work. So thank you, Drs. Anderson, Wilkins, for presenting today, and I will hand it over to you.
Thank you.
Thank you so much. Hello, everyone. My name is Melissa Anderson. I am thrilled to be here with my colleague.
Hi, I'm thrilled to be here too. Thank you so much for your warm introduction. My name is Alex Wilkins.
And you will see that we also have a third presenter today right here, who is Beamer, named Beamer, and he will probably be making his appearances throughout the presentation. So we're excited to be here to talk to you all about the research project that our team has been working on for the last 10 years. We have a lot to cover, so we're going to dive right in. In the first slide, we just want to disclose that we have no conflicts of interests. We want to thank our supports and recognize that if there's anything that you don't like in our presentation today, you blame us and not the National Institutes of Health. So for today's agenda, we will talk about the deaf community here in the United States and make sure that everyone here is on the same page in understanding what we mean when we talk about the deaf community. Next, we will review some common barriers that people tend to experience when engaging in mental health or addiction treatment. Then we'll talk about our work, how we've developed and researched signs of safety, which is our treatment approach that we will be explaining. And if hopefully we have enough time, we will have some questions and discussion. So that's our plan.
Okay, so I want to give you a short summary of the United States deaf community. When we talk about the US deaf community, we are not talking about anyone who has any particular hearing loss. Instead, we're talking about the 1 million people in the US who communicate by using American Sign Language and maybe other sign languages as well, or other spoken languages as well, but primarily ASL. This community embraces their deafhood, their community and cultural experience, their lived experience as full human beings, not as a sick individual needing a cure. Oh, sorry, go ahead, Melissa.
And I just wanted to say that deaf people have experienced a long history of oppression from the general community of people who can hear regarding, and what really is important is the free use of language. And I'm sure you all have heard of Alexander Graham Bell, a famous inventor of telephone technology. In the deaf community, Alexander Graham Bell is a bit of an enemy, because during the 1800s, Bell very strongly advocated against the use of sign language in deaf schools, residential deaf schools, and really wanted deaf children to become more like their hearing peers. He was fairly successful. Many deaf schools banned sign language due to his advocacy. Alexander Graham Bell also wanted to close a lot of the residential deaf schools because he didn't want deaf people to be able to meet, fall in love, and marry each other, because he thought that would cease the proliferation of deaf people in the United States. And his goal ultimately is to eliminate them from the population. So that's one really horrifying example of the oppression and discrimination that deaf people have experienced in the majority hearing world.
Now we're going to talk about social determinants of health. I'll abbreviate that SDH. As compared to hearing populations, we see a lot of inequities and imbalances in various areas. For example, deaf people are more likely to have adverse childhood experiences. They face neglect, they face oppression in the home, they face oppression in the school because of language deprivation, language delays and cochlear implant usage. They have a limited educational attainment as a result of some of the educational goals that hearing people have established. They have limited numbers of degrees and success getting through various levels of education. There's really high percentages of unemployment here in this country, and they often lack insurance and are stuck with substandard public insurance plans. All of these things impact mental health. And we know that public insurance, going back to that, is very different state by state. It might be okay in some states and not okay in others. So there's a lack of insurance, and all of this comes down to affecting mental health.
Because of what Alex just described, in the United States deaf community, we see a very strong degree of health disparity within the American deaf community. In general, deaf people experience 2 to 2.5 times the higher risk of mood and anxiety disorders, 5 times the risk of attempted suicide, 2 times the amount of trauma exposure, and 3 times the experience of problematic drinking. So this impacts mental health and substance use, and therefore justifies the need for dual diagnosis treatment.
So with that high need of treatment, we also experience a lot of barriers, which we'll demonstrate here. The primary barrier is language access. The US deaf community primary language is American Sign Language. It is hard to find available providers who can provide services in American Sign Language. Not enough, there's just not enough of us in the United States. Secondly, we try to find hearing providers with an interpreter, but this also is a big barrier because oftentimes institutions or clinics are not willing to hire such interpreters, aren't willing to pay for such interpreters. And deaf people quibble with that and then end up giving up. It's not worth the energy and effort to overcome those barriers. People think, well, why can't you just write back and forth? It might be a good idea, but for most deaf people, for many deaf people, English is as if it's a second language. Imagine going to therapy and having a conversation with your therapist in a second language, one that you might not be very good at.
I'd also like to add regarding Alex's second point, and providing ASL interpreters historically over the last several years we've really seen a shift from in-person, on-site, face-to-face interpreting to video remote interpreting. And for the healthcare system, video remote interpreting is often more convenient and cheaper. However, many deaf people really feel that video remote interpreting doesn't provide enough access. And often technology problems arise. The providers don't actually know how to set up and use video remote interpreting. That provides many more barriers to consider when video remote interpreting is offered in lieu of on-site interpretation. And we really advocate that the deaf person has the right to choose to have on-site interpreters. And the healthcare system doesn't agree. So that's always been our perspective, is that on-site interpreters are preferable. We tend to see two challenges, one being healthcare literacy, challenges to healthcare literacy. Many of our individuals that we work with have low funds of information and low health literacy. Because it's not as easy for a deaf person who relies on visual language to access that information. As hearing people, we navigate the world and we naturally acquire information. We pick things up as we live our lives. We are sponges. We have a constant input. Now imagine navigating the world without that input, that constant incidental learning opportunity. What that ends up looking like are gaps in information and health literacy. So in general, we see healthcare literacy and fund of information deficits equal to people who are recent immigrants to the United States. And part of the reason for this challenge, another reason for this challenge is that many deaf adults grow up in families who can hear and never have access to their family's health history. They're left out of that conversation most of their lives. They don't get that incidental input from their families.
So with all of this said, with all of this context we've just conveyed to you, imagine going into a doctor's office as a deaf person. You might have limited health literacy. You don't know your family history. You show up with a variety of problems, just even trying to find an interpreter, you encounter resistance. And you experience historical oppression from that medical point of view, from that whole system of medical care. Because the medical system focuses on one's ears, one's hearing, right? It's not looking at the whole person. So it's like, let's get a cochlear implant into you. Let's get you into speech therapy. So that's another experience of oppression that they're walking straight back into. The result of all of this is that deaf people feel less trust. They encounter more mistrust and fear. They have a reduced sense of cooperation and collaboration with healthcare providers because of that mistrust, and they might completely avoid the whole healthcare system, which leads us to worse health outcomes for this community.
In a way to overcome those barriers and the mistrusts, we established Deaf Yes to work with the deaf community and be innovative in how we develop addiction and mental health resources for the community in sign language that is expertly tailored to meet the needs of deaf people.
So with that background, we'll talk about how we developed our evaluation for the signs of safety. So we've got a little pop quiz for you. How many evidence-based therapies have been developed for or evaluated with deaf people in mind? Because we're short on time, I'll go ahead and give you the answer. The answer is 0.
0.
None whatsoever. Right? And here we are in 2024. We know that the mental health community has a lot of evidence-based therapies from which to choose. And some of them, but the problem is most of them don't fit the needs of this unique linguistic, cognitive, and cultural community. Oftentimes, these materials include very sophisticated strategies for tracking mood and behavior and thoughts. Think about all the paperwork you have to do to write all of that in English in your second language. Additionally, there's a lot of psychological jargon, which might not be accessible. And especially, there's limited health literacy. So that's a huge issue as well. Lastly, there are assumptions made based on hearing people's experience and their social and cultural norms that are at odds with how deaf people are in the world, how they see themselves in the world, and how they are in the world.
Another consideration is that many evidence-based therapeutic approaches depend on the client's ability to express their narrative with a clear beginning, middle, and end timeline. Sometimes that story is used for solving a specific problem by going through the progression of the story of when things happened to be able to identify patterns that have arisen repeatedly. And many trauma exposure therapies encourage people to express and share their trauma. Some of our deaf clients have experienced what we call language deprivation. Language deprivation means that there's been a lack of full access to language exposure during the ages 0 to 5, the critical language acquisition stage. 95% of deaf children are born to parents who can hear and families who can hear. And not all hearing families decide to learn ASL to use with their children. Many of those children who are in families that don't sign experience language deprivation. And it could be from that range goes from minor to severe. People who have experienced that kind of language deprivation can show issues with concepts of time, how to organize narratives and information into a beginning, middle, and end, the understanding of cause and effect, and the ability to express clear narratives. So this really becomes a barrier for traditional past present and future-based trauma exposure and narration. One possible solution that we found was a therapeutic intervention called Seeking Safety, which I can tell you a little bit more about in the next slide. Seeking Safety, the Seeking Safety manual is a CBT approach to trauma and or addiction, and it focuses on the first stage of trauma treatment, which means that it really focuses on the second stage of trauma treatment, which means looking at your past and to which really looks back at what we often see as treatment for trauma on TV and in the movies, where you're unpacking these experiences. That being the second stage. The first stage is really in focusing on coping skills and stability and being able to build those. And because they're based in the present, that need to retell the trauma narrative is not part of the treatment. Where we can really focus on behavioral health and trauma and addiction behaviors as well. With that approach, again, there's no need to retell the narrative of the experience itself, therefore eliminating that challenge of someone who experiences language deprivation from needing to tell their story.
What we're showing you on the screen now is content from the Seeking Safety intervention. So from what we've just talked about with the different barriers that deaf people face getting therapy, for example, you see here words in quotes, right? So this is a very English-based design, right? Which is just not well met for deaf people. In the third, you see a lot of text, and it's really important information, but it's difficult for somebody who might be stronger in their first language, ASL, and not so strong in English. This also requires people to sort of check in and check out, meaning look back on what happened last week, connect to how you're feeling now to how you were feeling last week, and making these narratives that might be challenging for those who have experienced language deprivation.
So we have worked for the last 10 years on something we call Signs of Safety, a Signs of Safety toolkit. And that uses videos and visual materials to teach the fundamentals of seeking safety in a way that meets the needs of deaf people. It uses the approach and structure of seeking safety. We've just added our elements of the toolkit. So now I will share one video clip, just a brief one, from Signs of Safety to give you a sense of what our work looks like. This clip is from a title the title is Integrating the Split Self. That's one of the topics of Seeking Safety. And so this is what we have made a video about. And it's a pretty abstract concept that we all have this internal pull when we don't know what to do and we are feeling at a crux. And so we took the visual ability of film to express clearly for our deaf clients and our deaf audience what that looks like. Now, this clip has no audience because it was made for deaf people and not for hearing people. So if you don't hear anything, that's what is supposed to happen. I just want to say something quickly, Alex, before you go.
Okay.
I do also want to emphasize that what we're showing today is the second version of Seeking Safety,
Signs of safety.
Signs of Safety. There were more than 100, 200 people involved in making this toolkit happen. And they are deaf people, therapists, deaf researchers, deaf people in recovery, deaf actors, deaf artists, just a wide variety of people who have worked together to make this happen. So even though Alex and I are the ones here right now representing the finished product, this really work came from and by the community. And I just want to acknowledge that and to thank everyone who has been involved in this over the last 10 years since the project began. Go ahead, Alex.
Definitely. I appreciate you saying that, because it's been in a community engagement, a collaboration, right? This is how we got here, because how we did this research, we couldn't have done it without the deaf community's input. So anyway, this is more Signs of Safety, and how you can see how we revised the Seeking Safety materials. It's more visually accessible. It incorporates visual metaphors rather than auditory or English-based metaphors. On the left, you have the sign for grounding incorporated into the image right above the word grounding. In the middle, which is my favorite one, it shows a mountain, recovery as a mountain, people who want to get there, right? It's not a quick ride, right? It's not a straight line. It's tough. And recovery, you go a lot of different directions and you encounter a lot of different rivers and forests along the way. So that concept seems to be really helpful in our community. Anyway, moving on.
So what's next? We are very grateful and fortunate to have just been given a 5-year grant by NIAA to work with the community on PTSD and problem drinking. And there's a deaf female-owned business called National NDS, where we interview people remotely. So for the next 4 or 5 years, we will be recruiting deaf adults who have PTSD and problem drinking behaviors. We will have 3 cohorts that we'll be working with. A person who lives in the state where NDT provides services. And then they will be randomized either to therapy as usual, 12 sessions of therapy as usual, or 12 sessions where they receive Signs of Safety treatment. We call it, the other one we call TAU, therapy as usual. In states where people live that are not able to really receive services from NDT, National Deaf Therapy, we're going to be assessing whether or not
they're just undergoing an assessment only, and they're put on a wait list otherwise.
So keep your eye out for our recruitment drive, which will be coming soon. I want to talk about who we've collaborated with for our research team. This is you will see Alex Wilkins here, who is part of the leadership team. Next, we have our collaborators from National Deaf Therapy, Megan and Alyssa. Of course, our study therapists who will be providing the treatment itself. The next box you'll see says deaf community advisors. Now, we don't use an advisory board approach. Instead, we have a role called a deaf community advisor. What that means is a person with lived experience for this study, lived experience of PTSD and alcohol use disorder. It may be that this person has no previous research experience, but what they bring with them is their lived experience as a deaf person who guides our study and are actual members of the research team. They attend weekly team meetings. They do work between meetings to make sure that every step of the process and every decision made is guided by the values and preferences and needs of the deaf community. The next square you will see is our research coordinating team, Kayla, whose parents are deaf, and Felicia, who is deaf herself. And they really help support everything that we do and help the team run smoothly and cohesively. And last but not least, our Science of Safety instructor, Tony Butland. So that's the team that will be working on this study, and we are thrilled to be working with this wonderful group of deaf and signing professionals and people in recovery.
So I want to let you know our website and deafyes.org. Our team is working importantly with the community to make transparent this work. We send the community updates on what we've been doing. We understand the importance of trust in this community. And oftentimes research is seen as some remote thing that we really want to make them privy to, and we want their feedback on. So we post not just about signs of safety, but all of our different arms of research. We do extensive outreach into the community. So you can contact us through that website as well.
Great, okay. So with that, we can open for questions and discussion. Thank you for being a great audience today, and just wanted to thank you all so much.
Thank you, Melissa and Alex. So we have several great questions, so I'll launch into them. First question, due to high increasing admission to Worcester Recovery Center and Hospital for deaf and hard of hearing members, how can we establish deaf-friendly substance use programs?
Alex, do you want to take it?
Sure, it's a wonderful question. It's a great question. I'm thinking of several approaches that would be beneficial. One is for people who need hospital level care that's offered at Worcester, where there's psychiatric care there, where they're in a building. Oftentimes,
do a dual diagnosis support.
Oftentimes there's not enough of that dual diagnosis support, and I think there's just 2 right now, right, that are open. I can't remember in the whole state. So we need to build within the state AUD and SUD services. How we do that, I'm not sure. I don't have an answer for how we get that done. We need state advocacy. We need a lot of knowledge, right? We need to increase the amount of knowledge that people have about the issues. Melissa, do you have anything to add?
I think also we do have a real dearth of inpatient and addiction treatment services for deaf people. But there is a growing number of peer support meetings and other community resources that I would like to see in inpatient settings more. Also, when we think about inpatient admissions and then the discharge process, if possible, for while someone's inpatient, for them to be able to receive services, while they are inpatient, they receive services. However, when they are discharged, they often feel that they are missing that robust wraparound of services that they experienced in the hospital. And to be able to provide them with the resources, there are NA, DRA, and AA meetings available all online. And for them to be able to be connected with community resources before they're discharged can really act as a bridge so that they don't fall through the cracks through their recovery journey. To be fair, I don't work in the inpatient setting. I haven't done that for several years. So it could be that that's already happening and I'm just not aware because I'm not up to date on the status quo. But I did want to mention that.
I would agree. And also I would add that Massachusetts is one of the states that has deaf recovery coach services. And I know that they've just hired a new one. So that's something that's really growing, which is an awesome resource that we have here in this state as well.
Great, that's a really excellent answer. Actually, I have a question related to that you've touched upon. So you mentioned, peer support would be great. You mentioned like 12-step would be great. And I know that for trauma and addiction, enhancing social support is really important, given potentially unhealthy social supports that have been in place, especially for addictions. Is there any way that we can adapt our interventions better for the deaf community and hard of hearing individuals to help them to build better social supports in their lives?
It's challenging. It's challenging because the deaf community is so small. So I think that this is one great example of how the hearing experience is inapplicable to the deaf experience. It's easy to tell, it's not easy to tell, I wouldn't say, but it's easy to suggest to your hearing clients that they should disengage from a specific group of friends and find a new group of friends, or people who are more positive influence, who are a healthier group of people to be around. And that's a different story in the deaf community. If you want to be friends with people who sign and who are deaf and have the same experience, have a shared experience and shared identity, that pool of people is very small. And the option of completely disengaging and re-engaging with a different group is not always possible. Sometimes it could be, but that's not always the case.
I would agree completely with that assessment. And also looking at different levels of financial privilege. It's easy for a deaf person, to go, it's not easy for a deaf person to say, go from Worcester to Boston to find a new group of friends to hang out with. It's not always possible for everybody. Another thing that I would mention in this case is the spread of AA Zoom meetings really does facilitate deaf recovery. I think AA meetings on Zoom have maybe 40, 56 deaf people all over the United States. So it's not equal to in-person, recovery meetings or meetings such as AA, but it is a tool.
Thank you. That's great. Okay, so next question is, this video is great. It really conveys an abstract concept that can be difficult to teach across the board. Is it okay to access these videos to help augment seeking safety groups for hearing individuals at DMH?
Sure. Why not? Everything is available on our website. It's open source. It's www.deafyes.org. So please look at it. We will put the links. We have links to YouTube, and you can use whatever you feel would be helpful. All of the videos are captioned, so they will be accessible to people who can hear and don't know sign language. You'll be able to read the English. But you could feel free to add your own voiceover if that's helpful. You can take on the different characters and do different voices if you'd like.
Great, thanks. Oh, now the next question is, as a hearing person using interpreters, they kept giving me the feedback that it's difficult because there aren't signs for mental health symptoms and it's difficult to explain. For example, asking an individual if they hear voices, have auditory hallucinations. The response was very literal, stating, "I'm deaf. I don't hear anything." Is this a common barrier?
Yeah. Do you want to answer that, Melissa, or?
Sure. So I think there are a few issues at play here that I could talk about with that question, which is it is a great question. The question is, do all English psychiatric concepts have direct translations into ASL? No, they don't. There are many mental health symptoms that need to be described because there is not a sign for word translation. So that part is definitely true. However, more and more interpreters are formally trained in mental health specialization. So they actually are the experts in how to translate those concepts clearly for a deaf individual. Related to the topic of, do deaf people hear voices? Which this is how we sign it, like the sign of people talking outside of a person's body. Yes, deaf people have auditory hallucinations, even if they are deaf from birth. And what that experience feels like for them is not something that I know. I'm not in their body, but we do have very reliable reporting over years and years of research that deaf people do in fact report hearing voices.
Great.
And I think also, just to add, this notion of hearing voices, it can be auditory, it can be also visual, right? So deaf people can quote unquote hear voices, but it looks different. It looks like signing in their head, or it looks like, somebody signing to them. So I think, again, as Melissa mentioned, the training, that situation requires somebody who can expertly navigate the jargon of, in the psychological sphere to what works in ASL for that particular deaf individual.
Specifically, interpreters need training.
Great, thank you. I really appreciate the wonderful presentation and excellent, discussion with these questions. So great job, thanks. All right, so we'll move on then.
Thanks so much. We're going to share a couple of slides that are relevant to the CEUs and CMEs. But what a fantastic presentation that was. I can't agree more. The texture of your work was so apparent in that. Really enjoyed it. Okay, so here are the QR codes. You will also see these links in the chat, posted in the chat or in the Q&A or both. But you can use your phone to read these QR codes if you like and access the surveys that way. The other thing that will happen, although we would love it if you, as I mentioned earlier, if you did the surveys now, is that you will receive a survey in your email with your registration email. So you can also fill it out afterwards if you prefer. And I think Megan and I just want to say thank you and kind of bask in this wonderful event.
Yeah, I want to thank everyone very much, the presenters, everyone who's been here, everyone who's contributed to this, and to everyone who's attended. It's been a fantastic day. It's been a lot of information to think about and incorporate into our practice. So really appreciate everyone's effort. It's really been a privilege to be part of this event, and I look forward to doing this again next year.
Yes, this was Megan's inaugural one of these, but we do really like getting your feedback. We will use it to change programming for next year, so please do let us know. It was an absolutely beautiful day outside today, so we even doubly appreciate your attendance. And I just, again, I have to say that the amount of work, from epidemiologic work to thinking about breaking down kind of barriers between these artificial sort of diagnostic categories, to thinking about the early risk of things like smoking or of using cannabis and its correlates with increased distress, as we saw in a dose-dependent way. This applied research that is being done, with Randy's work in the schools. And I think too, what we really saw is how these divisions have resulted in a public health, impact that has not benefited everyone, and perhaps not even benefited the majority. I also just really appreciated learning more about the issues that are important to consider with people who sign or are part of the deaf community. It was really wonderful. All right, we promised we'd give you time to complete this. There's a number in here, and I would like people to take some time to finish those surveys for us, and we will just look forward to seeing you next year. Thank you. Thanks, Megan. It was great doing it with you.
Thanks, Corey. It's been a great partnership.